myself. Kishoji, please give us a count and put us live.
Yeah, we will start in count of.
Tech support, please start.
Yep.
Kishoji, please give us a count.
Yes, ma'am.
And
Kishoji, are we
put us
live?
live.
Yeah, we will start in
Okay.
count of.
So, good morning,
Tech
one and
support.
all. Good morning, esteemed faculty members and delegates. We welcome you all for the webinar on recent updates in obstetrics and gynecology. I would like to introduce you all to our Masters of Ceremony, Dr. Sargam Soni. Kishoji, please next slide. Dr. Sargam Soni is the founder and director of Dr. Sargam Soni's Hospital for Maternity and Surgical Hospital, Mumbai. She is the founder of Devadan Charitable Foundation, and Dr. Sargam Soni is also a proud recipient of various social awards. The most notably is she has been an esteemed speaker on the prestigious TEDx Talks in November 2019. She has won the Young Meritorious Women Achievers Mumbai 2015 Award, Young Woman of Substance Mumbai 2016 Award, and the Indian Leadership Conclave Young Gynecologist of the Year 2017 Award, as well as she has been featured in the prestigious Vibjor magazine as Young Inspirational and Entrepreneur of 2018, the Hastakshar Ratna Award 2019 Mumbai, and she has also been featured as a Rising Queen of India in the November 2019 by the prestigious panel of Writers Platform. I will, ma'am, I hand over the dais to you. And
thank you so much for such. Thank you so much for such kind appreciation, and I'm immensely honored and humbled by all your kind words. So, good morning, namaste, Suchitra N, and I hope each one of us is doing amazing. And today we welcome to our first webinar of 2021, starting with a bang, and it is going to be followed by all amazing talks and panels by all the stalwarts of our fraternity. So here I start the welcome and the conference by introducing none other than our amazingly enthusiastic living legend on the way, Dr. Rajendra Nagargatti. It gives me immense pleasure to introduce him. He's the chairperson of Foxy Midlife Management Company. He's the chairperson of MOGS Midlife Management Company. And he's been such a backbone to each one of us, the youngsters, in helping us to achieve all that we are wanting to achieve and be a little like him. It also gives me immense pleasure to introduce none other than our gorgeous, enthusiastic, super amazingly talented Dr. Komal Chavan. She is the medical director of the Chavan Maternity and Nursing Home, which is located in Andheri. She's the chairperson of the Foxy Medical Disorders in Pregnancy, and she has so many amazing awards in her kitty. I fall short of words to introduce her, so I hand over now for the program to our very own Dr. Rajendra Nagargatti to introduce our chief guests of honor. Rajendra Nagargatti, sir, over to you.
Thank you, Dr. Sargam, for the kind introduction. So, good morning, friends. I wish to welcome all of you on behalf of the Mumbai Obstetrics and Gynecological Society, the MOGS webinar, in association with the ISOPAB Mumbai chapter. On this Super Sunday morning, the first MOGS outreach program for the year 2021. So a warm welcome to all of you. I bring greetings, and I also pay my regards to the Mumbai Obstetric Gynec Society team for giving us this opportunity. Dr. Rishma Pai Madam, President MOGS, Dr. Anaita Chavan, Honorary Secretary MOGS, Dr. Rajendra Sangpal, Honorary Treasurer MOGS, and the ISOPAB Mumbai chapter, Dr. Suchitra Pandit, Honorary President, Dr. Nagargatti, Honorary Secretary, and Dr. Urmila Sureka, the Treasurer. So with this, I would like to first invite our Honorable President of the ISOPAB Mumbai chapter, our iconic Dr. Suchitra Pandit ma'am, to, may I have the slide for Dr. Suchitra Pandit, please? Yes, thank you. So it's my privilege and honor to introduce my dear friend, Dr. Suchitra Pandit, who has reached such escalating heights in her career, both professional as well as with the Foxy and other organizations. She is consultant Department of OBGYN Surya Group of Hospitals, Mumbai, chairperson AICC RCOG 2017 to 2021, president ISOPAB 2018 to 2020, at the end of which tenure she initiated and started the Mumbai chapter of the ISOPAB. She's currently president of the Mumbai chapter of the ISOPAB, president organization Gestosis from 2015 to 18. She's been a past president of Foxy and the ICOG. She's been a Foxy representative to AOFOG from 2015 to 17. She's a chair of the CEFOG Medical Education Committee from 17-18, president MOGS 2013-14, a past former professor and unit chief at the LTMMC and the LTMG Hospital, Sion. She's a teacher of teachers. She's been a teacher there for 33 years. She initiated the Foxy Gestosis Hypertensive Disorders in Pregnancy Certificate course, which has done more than 100 so far. Conceptualized the Foxy Youth Mela for empowering youth. Done more than 300 such activities. Faculty for TOG committees, secretary Foxy, UNICEF, Sion Kishori Adolescent Empowerment Project. And she's done so many more such socially driven projects. She's got more than 100 publications, 125 publications, authored 5 books, including cesarean birth, fibroids, MCQs, and what have you. Awarded 35 orations and several prizes, winner of Lord of Planets Award by UK, also the FIGO Women's Award in 2018, MMC Award, and many, many other awards. So it's a pleasure to have you here, Dr. Suchitra Pandit, and may we have a few words of blessings from you.
Thanks, Dr. Raju. I would say it's a great job that you, as secretary of the newly formed Mumbai ISOPAB chapter, and Dr. Komal Chavan have taken up, and you all are doing, these webinars along with MOGS. MOGS is our parent body. All of us are members of the MOGS. So it gives me really great pride that, Rishma and Anaita have agreed to do this outreach program along with the ISOPAB Mumbai chapter. So it's like a mother and baby relationship, because we are just babies in the ISOPAB field as far as the chapter is concerned. So I'm again very glad that the topic that you all have chosen, the obstetric emergencies, because no matter how much we discuss, there are still so many things left to be taught. And, when you have great moderators like Sarita Balerao and Pandit discussing the issues, and so many expert panelists, a lot of things come out of it. And I think the viewers benefit, and we as organizers also benefit. And again, you have got young Turks like Shreya Prabhu, and yourself also, you're discussing about some of the important endocrine problems like hyperprolactinemia or hypothyroidism. I see so many wonderful faculty. So I'm very, very glad that you've chosen people from all across North, South, East, and West. And Charmila, yes, I see her name also there. So great that you are doing this particular program. I welcome all the faculty. Reena, hi Reena, she's there too. So I'm very happy that everyone's there, and it's wonderful that our parent body and our infant are working together for this particular program. And I must thank the glamorous Sargam Soni for fabulous introductions of both Rajendra and Komal, both very, very deserving people. And great. I wish the program great luck. And I'm very thankful also to our national president body, Dr. Usha Sharma, Meena Samant, and Dr. Parul Kotadawala, who is the West Zone ISOPAB Vice President. So great, and we'll take this forward and have a great webinar. Thank you so much.
Thank you, Dr. Suchitra ma'am. With regards to the MOGS president, I have a message from her that she would not be able to join because she's busy in another assignment, but we have a beautiful recorded message from Dr. Rishma Dillon Pai. She is currently the president of the Mumbai Obstetrics and Gynec Society. She's a past president of the Indian Society of Assisted Reproduction. She's also currently the Assistant Treasurer of the International Federation of Fertility Societies. She's been a president of the IAG 2018-19, President of FOXY in 2017, board member of the World Endometriosis Society, and as I said, currently the president of the Mumbai Obstetrics and Gynecological Society. So may we have the message, please, the recorded message.
Rajendra, may I also add that Rishma is also the vice president of the newly formed ISOPAB Mumbai.
ISOPAB Mumbai chapter, yes, yes. She and Dr. Ashwini Bhalerao are the vice presidents. Yes.
Hello, I'm Dr. Rishma Pai,
Voice.
President of the Mumbai Obstetric and Gynecological Society. Thank you all
Voice.
for joining
Voice,
us
little more
in this
volume.
outreach program, which is a very special program for MOGS.
This is a Magnum, sir.
This year, we've tried to make it more interactive, and we hope to present your cases and our experts. Also, some fun stuff with prizes and quiz, so do participate and enjoy these programs. MOGS this year has lined up a lot of wonderful academic programs as well as lots of MOGS masti. So stay with us through the year, join in our activities. We are very grateful to our academic partners for supporting us for these outreach programs. So thank you and see you through the year.
Thank you, Dr. Rishma. And now if I would like to invite the Honorary Secretary of MOGS, Dr. Anaita Chavan, to say a few words and bless the occasion. May I have her slide, please? Yes, thank you. Dr. Anaita Chavan, as you all know, she's an honorary consultant at Saifi Hospital and the St. Elizabeth Hospitals, a former professor and unit head at the St. GS Medical College and KEM Hospital, a very, very popular teacher. In fact, we just felicitated her this year at the Teachers' Day celebration of the Mumbai Obstetrics Society. A wonderful teacher to her students and to all the patients there. Joint Secretary of, she's currently the Honorary Secretary of the Mumbai Obstetrics and Gynecological Society, second joint editor of the Journal of Obstetrics and Gynecology of India, the Jogi. She's got numerous publications. She's done excellent work there. 17 editorials, 26 chapters, and more than 80 original articles and case reports. Her field of interests have been, I think, everything, but particularly so high-risk obstetrics, adolescent health, contraception, and urogynecology. So over to you, Dr. Mehta.
Thank you, Dr. Raju. And it gives me immense pleasure to see this collaboration with ISOPAB as our opening event for the year. I wouldn't say that MOGS is the parent and ISOPAB is the baby. And in fact, it's wonderful to collaborate with different organizations. And it's actually so interesting to see and hear people from all over the country. And if that's the only positive that we've had of the last year, it's that we are able to have excellent speakers and excellent faculty to join all our programs. It gives me great pleasure to welcome our two national speakers, Dr. Ashok Kumar and Dr. Krishnendu Gupta, who never say no to any invitation from MOGS. And of course, Dr. Charmila, who is always there and ever enthusiastic. So great job, Dr. Raju and Dr. Komal, in starting of the year with a great academic feast. And I wish this program all the very best. I think I have nothing else to say except let's start the program, which everyone is so eager to listen to. I think Dr. Reena would like to say a few words. So Dr. Raju, please allow Reena to...
Yeah, sure.
Thank you.
So good morning, friends, and it is my proud privilege to actually launch this the American Journal of Perinatology supplement, which was to be released at AICOG 2021, but the circumstances having had it, Dr. Alpesh Gandhi, sir, President, and I are the guest editors for this supplement, and it is covering comprehensive details of everything about progesterone, and whether it is rational, what are the various formulations available, And here, what I would like to say is that with ethics committee approval, we have done a study, and Shreya, Komal, Nirja, Mistry, and others were part of the study at Cooper Hospital, where we compared the oral, vaginal, and different types of routes of formulation. And I think Bhumika will be talking about it. And I'm happy to say that there was no difference. I'm not, and this was absolutely not pharma driven. It was done with proper protocols. And because most of our patients were not happy to use the intravaginal route, we thought of doing this study. So this will be actually, for a change, we will be getting print copies circulated to all of you. And of course, I've been told that they're going to do 10,000 print copies so that it can reach across the country. And I'm thankful to MOGS and ISOPAB for allowing us to use this platform for launching this supplement here today. Thank you very much.
Fantastic job, Reena. Fantastic.
Fantastic work. Congratulations, Dr. Reena.
Thank you so much.
I would like to invite the co-convener for today, Dr. Komal Chauhan, to say a few words.
Thank you. Thank you so much, Dr. Nagargatti, and it was a nice introduction by Dr. Sargam, a well-started program, and I would really like to, it gives me an immense pleasure, and actually it's an honor to be the convener of the program by the parent organization MOGS with our newly formed ISOPAB, and it is led by such stalwarts. We have Dr. Reshma Pai, who is always leading MOGS in such to great heights in spite of all these COVID and everything, and we are having so fabulous programs. And Dr. Suchitra Madam, who is always inspiring, and she has the new from ISOPAB chapter is actually flourishing. You know, we are doing so much and our name is everywhere. So Madam, it is really because of your guidance and your encouragement and your support all the time. And I would like to thank Anita Chauhan, Secretary of MOGS. So nice. Madam is always there for all the webinars and really appreciate that. Is real encouragement to see the Secretary joining in and blessing the programs. And it was a lovely announcement by Dr. Reena Vani. It gives pride to us to be associated with the American Journal. So with all that thanking, we have a nice academic program waiting. And I announce that please, all the viewers, please join in because we have fabulous talks, all evidence-based. And please be there with us today for an interesting academic session. Thank you so much.
Thank you. Thank you, Dr. Komal. So before I hand over it back to Dr. Sargam, I wish to, on behalf of both the organizations, invite and welcome all the wonderful esteemed faculty for today, beginning with our guests from out of Mumbai, Dr. Krishnendu Gupta from Kolkata, Dr. Ashok Kumar from Delhi, Dr. Charmila Ayavu from Chennai, and also Dr. Vijay Lakshmi Sheshadri from Chennai. I also wish to afford a welcome to all the rest of the faculty, the entire faculty, beginning with my co-convener Dr. Komal Chauhan, the MOCs, all young dashing youth council members, Dr. Sargam Soni, Dr. Amiti Agarwal, then the two speakers for today, Dr. Shreya Prabhu and Dr. Bhumika Kotecha, Dr. Rakesh Pandya, President of the Association of Fellow Gynecologists, Dr. Alka Godbole Madam, Dr. Bipin Pandit Sir, Dr. Sarita Bhalerao, Dr. Rajendra Sarogi Sir, teacher of teachers and one of the best persons to have with you in a time of obstetric emergency, Dr. Reena Vani, Dr. Rajeshri Katke Madam, and Dr. Abhijit Kher. So with this, I would like to hand it over back to Dr. Sargam Soni to take it forward. And let's have a wonderful webinar. Thank you, everyone.
Thank you so much, sir. Thank you so much. So let us start with the session one, and it gives me immense pleasure to introduce our young and handsome chairperson for the session first. That is Dr. Rakesh Pandya. He's the president of Association of Fellow Gynecologists of Mumbai. He's a consultant obstetrician and gynecologist in Malad since almost 25 years. Though he doesn't appear to be that old, but yes, he does have a great amount of experience. He's the consulting obstetrician and gynecologist at Raj Nursing Home, which is again in Pushpa Park, Malad East. He's a visiting consultant and obstetrician and gynecologist at Cloud9 Hospital, Malad. And not just this, he's also an honorary obstetrician and gynecologist at Manav Kalyan Kendra and Navneet High Tech, which is in Dahisar East. It Gives me immense pleasure to introduce our second chairperson for the day, which is the beautiful Dr. Alaka Godbole. She's the medical director at Akshay Surgical and Maternity Home. She's presented papers on various subjects and has won many regional and at many regional and national conferences. She's the winner of Thane Gunjan Award, and she's also the past General Secretary of TOGS. I hand over the further program to Dr. Rakesh Pandya and Dr. Alka Gorbole, who will be respectively introducing our speakers for the session 1. Over to you, Dr. Pandya.
Very good morning to all the star-studded faculty and all the delegates. And thank you very much, Dr. Sargam, for a very, very kind introduction. And just let me point out that the photograph which you showed was quite old. So you can note some differences. At the onset, let me thank Mumbai Obstetric Gynec Society and its president, Dr. Rishma Pai, and ISOPAR Mumbai chapter, and its president, Dr. Suchitra Pandit, for inviting for this particular program. And let me congratulate Dr. Raju Nagarkatti, convener, and convener Dr. Komal Chavan for organizing such a wonderful webinar for all of us. And let us begin with recent advances in obstetrics and gynecology. Hyperprolactinemia, its consequences and management, is going to be the first talk delivered today. And as we all know, prolactin is a lactotropin, mainly enabling the mammals to produce milk. But does it have many other roles to play? That will be told to us by the speaker today. This particular lactoprotein also plays a very important role in maternal behavior. Increased levels decrease estrogen in females and testosterone in males, causing so many clinical manifestations like involuntary infertility and amenorrhea and oligomenorrhea, and also galactorrhea. So I invite our first speaker, Dr. Shreya Prabhu. Can we have her introductory slide, please? Dr. Shreya Prabhu is an obstetrician and gynecologist at Mukund Hospital and Surya Hospital, and assistant honorary at HBT Medical College and Dr. R.N. Cooper Hospital, and special interest in endoscopy and high-risk pregnancy. And she has won prizes as Best Youth Council member in 2018-19 and subsequently in 1920. So over to you, Dr. Prabhu. Dr. Prabhu, you are muted. Yeah, thank you.
Thank you very much. Thank you very much, sir, for such a kind introduction. Just let me share my slide. Okay. Good morning, everyone, respected chairpersons, my seniors present here today, and all the delegates watching this webinar. I welcome you on behalf of MOGS and ISOPAP for this first webinar of the year. Now, my topic for today is hyperprolactinemia, and I know all gynecologists are very well versed with it, but I'm going to touch upon a few details for the benefit of residents, if any are watching. Hyperprolactinemia is increased prolactin level in the blood. Now, prolactin, which is secreted from the anterior lobe of the pituitary gland, which is so beautifully protected by the sella turcica in the brain. It is a 19-9 polypeptide hormone made by the pituitary lactotropes. Now, its normal level is somewhere between 10 and 25, sometimes 30, depending on the reporting. Half-life being 20 minutes, and it is metabolized by the liver and the kidney. There are different isoforms of this prolactin. It is like the major one is the little prolactin, which makes up for 80 to 90% of the prolactin circulating in our body, and the molecular weight is 23,000. The second is the big prolactin. the big prolactin. Now, big prolactin has an additional arm which increases the size of the prolactin here, and it accounts for around 8 to 20%, and the molecular weight is 50,000. Then there is a big prolactin, which accounts for 1 to 5%, and it is a double isomer. So its molecular weight increases to 1,00,000. Now, how is prolactin actually regulated in our body? There are a lot of factors which stimulate the release of prolactin, including stress. And if we talk about hormones, the hypothalamic hormone, which regulates TSH release, that is thyrotropin releasing hormone, is a major factor for increasing the release of pituitary of prolactin. Now, there is only one factor which actually is the regulatory for prolactin, or which decreases or controls the prolactin release, which is dopamine. Now, anything that affects the dopamine release is going to increase the prolactin level in the body. How do we check for incidence in the general population? When it's seen that any healthy adult is there, the incidence is seen to be 0.4 to 5%. Among women who present with amenorrhea, it is seen that it is 9%. With galactorrhea, it is 25%. And among women who present with both amenorrhea and galactorrhea, it is 70%. As well as males who present with impotence or infertility, generalized if they come, then it is 5%. Now, the etiology is basically most of the times physiological, which is pregnancy, lactation, exercise, even intercourse, sleep, deprivation, or stress. So that is why when we ask patients to do a prolactin test, there are certain things that we need to advise. One of it is that they should sleep well. Second, that they should not have an intercourse the night prior. There should be no nipple or breast stimulation, and the patient should not be stressed out during that time. We also add certain other things like they should go nil by mouth, and the next is that they should go directly to the collection center where they're going to process the sample, because there is a lot of deterioration that happens from the collection center to the place where they actually check it. There are other pathological causes at times, which can be secretory pituitary lesions, which is prolactinoma, or other secretory lesions from other cells there. Other non-secretory lesions like germ cell tumors, craniopharyngiomas, and other causes which are there, out of which renal failure and cirrhosis basically hamper the metabolism of prolactin. That is why the level of prolactin in the blood rises. Other drugs which are responsible are neuroleptics, which are phenothiazines, haloperidol. Then antihypertensives, calcium channel blockers, methyl dopa, tricyclic antidepressants, then even some basic drugs like ranitidine and opiates. All these inhibit the production of dopamine and hence remove the inhibitory factor from the control of prolactin, increasing the prolactin level. Now, what are the major symptoms that patients present with? The major symptoms in females are usually oligomenorrhea or amenorrhea, galactorrhea in around 80% of the women, infertility. Loss of libido is something that people ignore, but it is a very, very important factor. Vaginal dryness, weight gain, hirsutism. In males, it is loss of libido, which patients come up with, or infertility, impotence, visual loss if there are no other symptoms or neglected symptoms, and the patient directly comes with visual loss because of compression of the adenoma on the optic chiasm. Now, why amenorrhea and infertility? The basic thing is that hyperprolactinemia causes reduced GnRH by negative effect. And that is how it leads to reduced LH and FSH, causing hypogonadism. But these symptoms also vary depending on how much is the prolactin level in the body. So if the prolactin level is between 31 or 30 and 50, the lower mild hyperprolactinemia, then patients usually have mild symptoms like decreased libido, short luteal phase. So they'll have shorter period cycles, then infertility. If it ranges between 50 and 75, then maybe oligomenorrhea is a major symptom. And anywhere below 100, but more than 75, patients usually start presenting with galactorrhea, amenorrhea, and hypogonadism. Now, what are the objectives of treatment? When we treat patients with hyperprolactinemia, what are the major things that we have to look at? So basic thing is to get the patient's gonadal function back to normal. If patients are presenting with infertility, we have to see that the patient conceives or gets back the fertility rate. And of course, prevention of osteoporosis, because bone loss is another factor that comes in. If the patient is having an adenoma in the pituitary gland, then correction of the visual or neurological abnormalities or any other pituitary symptoms are the major concern. The patient, say, comes with nipple discharge. Usually as gynecologists, we get patients more with, there are not many patients who will complain of loss of libido, but patients do concern and come with nipple discharge. Now, what are the different steps that we follow? The management of nipple discharge is that first thing, you take a thorough history as to how the discharge comes. It might be free flowing discharge or discharge only on pressing the breast or the areola, and a thorough physical examination, including the examination of the axilla for lymph nodes. When we see this, we need to know whether the discharge is unilateral, single duct discharge, bloody or serosanguinous discharge, whether it is associated with a breast mass or no. All these things need a thorough further checkup, maybe a mammography, which is a must. If the discharge is bilateral, multiductal, milky, then you check for the prolactin levels. Mostly it is galactoria because of hyperprolactinemia. And if there is any doubt, if the discharge is yellow or green or brown and you're not sure whether it is galactoria, then you should always do a Sudan 4 screening for fat globules that confirms the presence of galactoria. What if there is galactoria and elevated prolactin? So then you do a MRI of the pituitary gland. And that, if it is normal and the patient becomes asymptomatic by the time, then you just follow up the measurement of prolactin after 6 months or a year. If the MRI is normal but the patient is symptomatic, or the MRI shows microadenoma and the patient is symptomatic, then you need to start the patient on dopamine agonist therapy. If the patient has macroadenoma, then of course you need further investigation. Microadenoma and you've started the patient of dopamine agonist therapy, the prolactin levels need to be checked every month after the therapy is initiated. And if there are any new symptoms which start, along with galactoria, there is visual disturbances and all, then we need to repeat the MRI within a year to see whether there is any progress. Now, if the patient has macroadenoma, then we need to check the other hormones that are released by the pituitary to see whether there is any change in their levels, like the growth hormone, the ACTH, because there at times, because of the pressure effect, there might be decrease in the other hormones or sometimes hypertrophy and increase. So if there is only isolated prolactin excess, then dopamine agonist therapy is given. Now, on that, if the patient has normal prolactin level, or the prolactin level reduces within 6 months, and the patient is asymptomatic, then we repeat the prolactin level after 4 to 6 months, and an MRI is done every year. But if the prolactin level is reduced, but the patient is still symptomatic and the symptoms are not relieved, then we need to think about a surgery, even if the prolactin levels are not reduced at all. The other effect, which is also called as the hook effect or the stalk effect, is when the prolactinoma is very big, but it does not show the level of prolactin is not very high as to correlate with the size of the prolactinoma. That means there are a lot of big prolactin in the blood which are not being accounted for because they do not bind with the collection and does not show the prolactin level. So that is why then the dilution is increased and the prolactin levels are checked again. But these patients usually need a surgery. What if these patients are having drug-induced hyperprolactinemia? Now, in those patients, you try discontinuing the medication for 3 days and then give an alternative drug and check the prolactin levels after you have discontinued the drug. Then in cases, if you can't discontinue the drug, because there are some psychotropic drugs which can't be discontinued in patients because it might be dangerous for the patient. In these cases, then we change the, instead of changing the therapy, you do an MRI and just keep a watch on the prolactin levels. If there are patients in whom there is hypogonadism and the drug cannot be changed or cannot be discontinued, then we wait and we start the patient on hormonal therapy like estrogen in females, testosterone on males to take care of their hypogonadism. Now we're talking about dopamine agonists. Now, which are the dopamine agonists which are available? First is the most old and longest track record is bromocriptine. The newer drug that has come into the market is cabergoline, but of course it has also been here for some years now. Quinagalide and pergolide are drugs with limited access because they are expensive, and plus they are used and kept reserved for cases where the patients are resistant to bromocriptine and cabergoline and where surgical approach is not warranted. Now, a little bit about bromocriptine. This drug was, found in 1971, and since then it has been used everywhere, and it works beautifully on hyperprolactinemia. It has an optimum dose for an optimum response, but you can't start the dose directly from the start. You need to escalate the dose slowly. So you start it with 1 milligram to 1.5 milligrams at bedtime, increasing the dose every 2 to 3 days by 0.5 milligrams till you reach a maximum dose of 2.5 milligrams twice or thrice in a day as per needed. Now, when there are patients who are complaining of hypogonadism or galactoria or infertility, usually a dose of 2.5 milligrams 3 times in a day is good enough. That is 7.5 milligrams per day. Usually the patients respond to this treatment. But in prolactinomas, where you need higher drug dosages, at that time, even doses of 2.5 milligrams 6 times a day or 6 hourly or 8 hourly, even 5 milligrams 6 hourly is given, but it has to be seen that the daily dosage does not exceed 30 milligrams. Cabergoline, at first you start with a dose of 0.25 milligrams twice a week. And then slowly you increase it to maybe 0.5 milligrams twice a week, depending on what the patient needs, even 1 milligram twice a week. But in prolactinomas, sometimes you even need dosages of 3 to 3.5 milligrams per week. We have seen with dopamine agonists there are a lot of studies in which all these dopamine agonists have been used, and they have seen that they have shown beautiful reduction in tumor size by 62%, resolution of visual field effect, obviously because of the shrinkage of the tumor, the pressure effect on the optic chiasm is gone. So that's about 67%, resolution of amenorrhea, 78%, resolution of infertility in around 53%, improvement of sexual function is 67%, galactoria is 86%, and normalization of prolactin level is seen in about 68% of the patients. Now, over a period of time, they have realized that these patients also have resistance to dopamine agonists. Now, how do we make out that the patient is resistant? A failure to achieve a normal prolactin level on maximum dose, a failure to achieve a 50% reduction in tumor size, or failure to restore fertility in patients. Now, it is seen that 25% of the patients are resistant to bromocriptine and 10% are resistant to cabergoline. So even in this, you can make out that, cabergoline is a more efficacious drug over the period of time now. If the patient is resistant to bromocriptine, you promptly change the medicine to cabergoline. If patients can't tolerate the high doses of cabergoline, which sometimes even go up to 10 milligrams and 11 milligrams, then you need to promptly go towards operating the patient and removing the adenoma from the pituitary. And even if surgery is not an option, then radiotherapy is an option for these patients. Dopamine agonist therapy can be tapered off once the prolactin levels have come back to normal. In prolactinomas, say over a period of time, maybe even 2 years it takes for the complete shrinkage of the tumor from the pituitary and the prolactin levels to come back to normal. You need to see that there is no visible tumor seen on the MRI. And sometimes when patients have come with amenorrhea or oligomenorrhea and the patients reach menopause and the prolactin levels are normal, then obviously the dopamine agonist can be stopped. Which patients need surgery? This is very important because patients, like what we discussed, if they are resistant to dopamine agonist, then you promptly directly go towards surgery. Intracellular tumors which are not responding to the medicines, then you still go towards surgery. And last, but immediate surgery is warranted when the tumor is compressing on the optic chiasm. But if there is any pressure effect because of any pathology outside the cella, then and it is not compressing the optic chiasm, then surgery is not warranted because the outcome is not very good. Now, this is one of the study in June 2019 where cabergoline was used in hyperprolactinemia and infertility. It was seen that galactoria was resolved in around 80% of the patients. Menstrual cycle was normalized in 93% of the patient, and successful conception was achieved in 85% of the patients. Now, cabergoline in infertile patients with hyperprolactinemia was also studied in 2011 and published. So in this study, 183 infertile patients were given either cabergoline or bromocriptine in a dosage of cabergoline 0.25 milligrams twice weekly and bromocriptine 2.5 milligrams twice a day, and were monitored. The patients who received cabergoline, 82% of the patients conceived, and 56.4% who conceived received bromocriptine. So overall, in this study, it resulted that cabergoline had a better pregnancy rate, significant reduction in prolactin levels, relief of galactoria was faster, and it had definitely had lower side effects. Now, cabergoline has been tried in pregnancy, but FDA has reported it as a category B drug because of insufficient clinical data in pregnant women. A prolonged treatment with cabergoline during pregnancy is reported without any teratogenic effects on the fetus. Now, this has been given in such patients who have prolactinomas and have conceived on cabergoline. This is a study in 2008 where patients who, like what I said, who had prolactinoma were being given cabergoline for the prolactinoma and the prolactin levels, and they conceived on it. It was seen in this study that they did not show any increased risk of miscarriage, spontaneous abortion, or low birth weight. So definitely cabergoline had higher efficacy and efficient tolerability. This was another study in 2019 which has shown successful pregnancy and lactation with dopamine agonist treatment of prolactinoma. Fetal exposure for the first 4 weeks of pregnancy did not show any grave results. Points to remember. Now, basically, overall, what we have discussed, dopamine agonists are the drugs of choice for hyperprolactinemia, whether you use bromocriptine or whether you use cabergoline. Both are to be started from a low dose and increased gradually. Surgery is advocated in cases of pressure effects or in cases of resistance to dopamine agonist. And it definitely, cabergoline has a better safety profile and is more efficacious. And patients are more willing to take cabergoline because of the dosage regime, because they have to take it only twice a week rather than remembering the doses 3 times and 4 times per day of bromocriptine. So that is why the acceptability from the patient's point of view for cabergoline is much more than for bromocriptine. With this, I would like to thank our chairpersons, and I would like to thank Suchitra ma'am, Rajendra sir, Komal ma'am from ISOPAB, our dynamic president, Dr. Rishma Pai, secretary, Dr. Anaita Chauhan, and Rajendra Sangpal sir for giving me this opportunity to deliver this talk today. Thank you very much.
Thank you very much, Dr. Shreya Prabhu, and congratulations for a very lucid, elaborated talk discussing hyperprolactinemia and its management. And before we go ahead, I think we should also concentrate on the stress-induced hyperprolactinemia, which is seen more and more commonly today. and the borderline hyperprolactinemia that you see in the PCOS patients. Thank you very much. I hand over the mic to Dr. Sargam soon.
So beginning now, I would invite Dr. Alka Godbole to introduce our second speaker for the day and carry this program forward. Over to you, Dr. Alka.
Hello. Hello.
Hello, ma'am. We can hear you.
Hello. Good morning. Good morning, everybody. Nowadays, natural micronized progesterone is gaining more and more importance in daily gynec and obstetric practice. So I think we should gather more and more information about this from Dr. Bhumika Kotecha. May I have her introductory slide? Okay. Dr. Bhumika Kotecha Munde is a director of Women's Clinic, Charni Road. She is a consultant obstetric and gynecologist from Saifi Hospital, Wockard Hospital, Messina, and St. Elizabeth. She is having special interests in advanced OB-GYN ultrasonography and minimal invasive endoscopy. She is an active youth council member of MOGS since 2016, and she is elected as Yuva lead of MOGS in 2020. So let us gather some information from this young and talented Bhumika, doctor.
Good morning, respected seniors, teachers, and my colleagues. Thank you, Dr. Alka, for this kind introduction. And thank you, ISOPAB team of Dr. Suchitra Pandit, Dr. Rajendra Nagarkatti sir, Dr. Komal Chavan madam, and also I would like to thank Dr. Rishma ma'am, Anaita Chavan ma'am, and Rajendra Sangpal sir in believing in us. Thank you so much. Can I have my slide, please? Hello?
Yeah, ma'am, one sec.
Yeah. Yeah. So today, my topic for today is first trimester maintenance of pregnancy with oral NMP-SR. Now, this NMP-SR is natural micronized progesterone sustained release. Progesterone, progestation hormone. The name itself suggests that it's a hormone which favors pregnancy. So progesterone supports pregnancy right from conception till delivery. It is very well said that a good beginning is half the battle won. Laying strong foundation in first trimester, that is why would be very, very important for a successful pregnancy. Progesterone helps, it plays a very important role in two ways. First is implantation and second is immunomodulation. Next slide, please. So as I said that my topic is about first trimester maintenance with the help of NMSR. Now, first trimester, we would start from the day of first menses, of the missed menses. But in case of recurrent miscarriages and ARTs, which need extra attention, the etiology would actually start from the luteal phase. So first, we would concentrate on luteal phase to begin with. So let us just have a look at what would be the definition of luteal phase defect. Now, this luteal phase defect means inadequate secretory transformation of endometrium due to deficient progesterone production. What is the prevalence of luteal phase defect? It has got a very wide variation from 3 to 20% in an infertile patient and 5 to 60% in patients experiencing recurrent pregnancy loss. It has also been seen that the blood flow, luteal blood flow, decreases significantly with the progesterone concentration being decreased. Now, how would we diagnose, or what would be the level of progesterone to label it as a luteal phase defect? the diagnosis still remains very controversial, and it has been long existing. Now, this defective luteal phase in the natural cycle is defined to have serum mid-luteal progesterone levels of less than 10 nanograms per ml. Somehow, actually, it just means that there is the correlation between the serum mid-luteal progesterone levels and endometrial maturation is lacking. That means they are not going hand in hand. So the most reasonable consensus of defective luteal phase defect is a lag of more than 2 days in endometrial histological development compared to the expected day of the cycle. What are the different proposed methods for the diagnosis of luteal phase defects? Like we all know, it is basically basal body temperature charting, urinary LH surge detection kits, serum progesterone levels, and endometrial biopsy. But none of them are very, very definitive, unfortunately. Next slide, please. The progesterone levels. What are the limitations of progesterone levels? Unfortunately, there are no standard characterization of progesterone levels during the luteal phase in a normal fertile female as well. So, no minimum progesterone concentration has been defined for the luteal function. Furthermore, it has been seen that the corpus luteum function varies from cycle to cycle, even in a normal fertile patient. So, random serum progesterone concentration levels are not a valid clinical diagnostic tool to evaluate this luteal phase deficiency. So, what would be the management? The management would be, the first approach would be the treatment of the potential underlying condition like hyperprolactinemia, thyroid dysfunction, and things like that. But if there is no underlying abnormality identified, the treatment would be an empirical one, that is by promoting endometrial maturation, enhancing endometrial receptivity, and support implantation and development of early pregnancy. So the management goes with HCG in luteal phase and progesterone. Now, how will the HCG help? HCG, it has been seen that if the corpus luteum is somehow to be deficient one or not a very good one, and that is why it produces insufficient levels of E2 and progesterone, and hence to rescue this corpus luteum, HCG would be needed. But unfortunately, the disadvantage is that it sometimes increases the rate of OHSS. So we all have nothing but progesterone left to support this luteal phase defect. Now, the luteal phase support in pregnancy by progesterone helps in the following ways. It supports the endometrial growth. It improves blood flow for oxygen by increasing the oxygen supply. It keeps the myometrium uterine muscle quiescent, and it also immunomodulates the entire uterine milieu. Next slide, please. So the progesterone helps successful implantation by making the endometrium in phase by forming penopods, and helps in decidulization and endometrial receptivity. These are the two pictures electron micrographically showing the penopod formation with the help of progesterone. Next slide, please. Now, the progesterone helps in immunomodulation by maintaining the favorable Th2 type and shifting from Th1 to Th2 balance is reduced. It modulates chemokines by transcription factors, and it inhibits tissue rejection and favoring our conception. Next slide, please. So all in all, progesterone induces proliferation and differentiation of stromal cells, prepares endometrium for blastocyst implantation, and controls endometrial development, thus helping our indispensable and maintenance of pregnancy. Progesterone, there are many commercial preparations available. The natural ones are micronized progesterone, having various preparations in the form of oral, vaginal, intramuscular, subcutaneous, etc. And the synthetic one being dihydrogesterone, medroxyprogesterone, gestrinone, norgestrol, and demigestrone. So the natural progesterone obtained are from the soya bean and Mexican yam roots. Same chemical structures are that as that of the physiological progesterone as that in the human body. Now, natural micronized progesterone. How does natural micronization help in progesterone, increasing progesterone levels in the body? It helps by decreasing the particle size, enhancing the dissolution. Its destruction in the GI tract is reduced, and hence its half-life is increased. So a maximum serum concentration are achieved more rapidly with orally administered micronized progesterone than with injected progesterone levels. Now, the bioavailability of micronized progesterone is similar to natural steroids. Efficient delivery of progesterone can be accomplished by using micronized form of hormone. It has been found that micronization of progesterone reduces the particle size to less than 10 millimeter. And suspension in oil and packaging in gelatin capsule has shown to further enhance intestinal absorption of this micronized progesterone. So micronization would definitely increase the progesterone levels in the patient's body. Next slide, please. Now, natural versus synthetic progesterone. It has been found that the micronized natural progesterone has minimal to no effects on the mood, HDL cholesterol levels, and pregnancy outcomes. Whereas the synthetic progesterone affects mood, decreases HDL cholesterol levels, and it adversely affects pregnancy outcome. Natural micronized progesterone may cause fatigue and somnolensis, whereas the synthetic progesterone causes edema, abdominal bloating, anxiety, irritability, depression, and myalgia too. Next slide, please. Now, another proposed absorption of oral NMP SR is also by its lymphatic absorption. They say that there is gradual dissolution and erosion of the polymeric matrix, which will facilitate its lymphatic absorption and thus bypassing the hepatic first pass metabolism to reach the systemic circulation. Now, progesterone sustained release tablets has been found to have gradual release of progesterone for more than 16 hours, which would suffice for a single daily dosage. So it would help, NMP minimizes progesterone release in upper GI tract, and which helps to prevent pre-systemic metabolism by at successive steps in intestinal bacteria, intestinal wall, and liver as well. Now, UK MHRA guidelines suggest that progesterone levels of more than 40 nanograms per and it's been found that this natural micronized progesterone SR in various doses from 200 to 400 can maintain mid-luteal serum progesterone levels from 20 to 40 with a half-life of 18 hours. Now, this is a very article which has been published in 2009 American Journal of Dermatology. It actually says about evidence-based recommendation in the management of threatened miscarriage. It's been, can we have the next slide, please? Next one. So the FOXY recommendations over here are that lower serum progesterone associated with threatened miscarriages, and there are several routes of administration: oral, vaginal, IM, transdermal, and various formulations of progesterones are available and clinically used in threatened miscarriages. So the oral progesterone are favorable in view of patient compliance. Oral supplementation with sustained release progesterone may show improved patient compliance, definitely. There has also been an article which says that NMP would be a safer choice over dydrogesterone. There has been some controversy where dydrogesterone is found to have 3 times more risk of congenital heart disease in cases of exposure in early pregnancy. However, in the Fertility Sterility Report Journal, NMPs have found to have no increase in risk of congenital anomalies, and it is found to have it not to be a cardiac teratogen. Can we have the next slide, please? Now, in 1999, FDA have said that micronized progesterone is widely used in IVF treatment, and they have categorized it as category B drug, and they have said that it appears progesterone treatment does not increase the risk of congenital birth defects. And although a few investigators reported an association between progesterone treatment and hypospadias, its relationship with the widely used natural micronized progesterone is unlikely. Next slide, please. Now, we all know that progesterone has also been used vaginally. So we'll just see how oral and vaginal routes differ from each other. Intravaginal route has been widely used in IVF. They say that there is high progesterone concentration due to a first uterine pass effect, and there is counter exchange in the progesterone transport between anatomically closed blood vessels. Next slide, please. It has been found that the high levels of progesterone through intravaginal route are because of the intracervical aspiration, countercurrent transfer progesterone from the vaginal veins, direct diffusion of progesterone from vagina to the uterus, and transport of progesterone to the lymphatic and venous circulatory system. Next slide, please. Hello? Hello? Yeah. Now, this is a very informative expert review which has been published in 2020, and it has given how micronized vaginal progesterone would prevent miscarriage, but its critical evaluation by various randomized studies which have been published. So here they have basically talked about 2 main studies, which are the PROMISE trial and the PRISM trial. Can we have the next slide, please? These 2 trials were large ones, high quality, multi-center and placebo-controlled trials. Now, the PROMISE trial was basically for progesterone in recurrent miscarriage, and the other trial, which was the PRISM, which is progesterone in spontaneous miscarriage. Now, the PROMISE trial included 836 females from 45 hospitals in United Kingdom and Netherlands, and it was found that 3% greater live births were noted, but with substantial statistical uncertainty. Second trial, the PRISM trial studied around 4,000 plus females from 48 hospitals in United Kingdom again, and it again showed that there were 3% greater live birth rates with progesterone, but the p-value was of again not very significant. The Foxy Possession Statement, which has been out in 2014 and 15 under the guidance of Dr. Sanjay Gupte, along with Dr. Prakash Trivedi and our own Dr. Suchitra Pandit Madam, it says that the progesterone support is beneficial in women presenting with the clinical diagnosis of threatened miscarriage, with a relative risk reduction in miscarriage rate of 47%, and with the use of progesterone. However, the argument for the use of progesterone is that there is no evidence of harm and some evidence of benefit, although not coming from huge multi-center trials. The decision should be made on clinicians' discretion. according to the case. In the end, I would like to conclude with this huge Cochrane database systemic review of 2019. It concluded that for women with unexplained recurrent miscarriages, supplementation with progesterone therapy may reduce the risk of miscarriages in subsequent pregnancies. However, they have not mentioned the route of this progesterone administration. Thank you, everybody. Also, I would like to make additional I would like to give an additional information over here. The Foxy has come up with a fresh new article under the leadership of Dr. Alpesh Gandhi with our Reena Vani madam. And this article is again about a study conducted on oral NMPSR with our kind academic partner for today's event. So I would now like to invite Dr. Reena Vani to throw some light on the same.
Thank you very much. And I will just take a minute here. Basically, the Bhumika has presented beautifully all the summary of various studies. But from the West, most of the studies are only on vaginal progesterone. We don't have enough evidence on oral, although thousands or maybe, I would say lakhs of units of oral progesterone are being sold worldwide. Particularly in our country, because women have a lot of hesitation of inserting those tablets into the vaginal part. There's increased vaginal discharge with local tablets. Hence, we thought of doing a comparative study between oral 400 at night, oral twice a day, both sustained release preparation, and the intravaginal with ethics committee approval. So the study basically showed that the prevention of miscarriage and reduction in preterm labor. We have actually followed up these women up to delivery in all three groups. And we have actually found that there was no difference in the three groups. Now, this, according to me, is not a negative finding. It's a good finding that when a lot of people run down oral progesterone saying that it is useless. You're just giving it like that. But some of our patients don't want to take the vaginal. But having done a scientific study, at least now I feel reassured that patients who are taking oral, whether it is 200 twice a day or even 400 at night, there was no difference in the outcome. They were equally good, that the reduction in miscarriage and the reduction in preterm labor. And I'm happy to say that we had 50 patients in each group after statistical input. And there was a the statistician involved, and we got it analyzed. So bottom line of that study was that all three routes are equally good, at least in our women, but definitely we need larger studies. So in fact, that journal we are releasing is not just about this article. It has actually got 10 chapters from various people, ranging from Dr. Sonia Malik, Dr. Jaideep Malhotra, a pharmacologist who's the head of department of Nair Hospital. And I'm sure if you all go through it, you will get a better insight into a tablet which we are using left, right, and center. We just thought we should know about it better to be scientifically based. And thank you, Bhumika, for giving such a wonderful, detailed discussion from the origin of the progesterone to various scientific evidences. And thank you for letting me just speak for a few minutes. Thank you very much.
Can I ask one question, Reena?
Yes, Charmini.
After how many weeks did you give your...
So we gave the patient, the trial design said that we are going to give it up to 20 weeks because our definition of abortion in our country is still we were using 20 weeks as the cutoff. So we did an initial evaluation, how many women reached 20 weeks. They were given the option that do you want to continue it further? And almost all the women chose to continue it. And of course, we were giving it free through the trial. So there was no cost involved. And this was done at two centers. One was my colleague, Dr. Nirja Mistry, who had a private clinic. We had registered her center also. And one was at Cooper Hospital. So most of the patients continued. Then we reassessed them at 32 weeks. And then finally, till all of them either delivered or aborted or whatever. So the outcome was seen up to the time of delivery, which was in fact why the trial took a long time to be published. We wanted to do it last year, the publication, but we waited till each and every patient had either aborted, delivered or otherwise. And the results of that we have published in this supplement.
So you gave it up to 32 weeks.
We followed them up to term, but the
but
medication
the
was
progesterone was given up to.
Yes, for that, to prevent preterm labor, was there any difference in the 3 groups? Because it has been suggested that in prevention of preterm labor, especially in patients who have had any risk factor, so this was not given in prophylactically to all women. They were women who had risk factors or had other factors, and then they were put into the 3 groups.
Okay, were they having any oral NMP, the NMP SR, not the oral capsule?
So it was oral 400 NMP SR at night was one group. The other group was 200 SR, which is the one from today's academic partners, given twice a day. And the third group was the Myprogen vaginal tablet, available free of cost in our hospital. So with ethics committee approval, we did this in the various groups of women and followed them up to delivery. So
not the oral capsules, not the oral capsules.
No, not oral capsules. Both were the group A and group B sustained release preparations.
Yeah. But were they having any side effects like headache, nausea?
So, Dr. Godbole, the side effect profile was also similar. Only thing, the patient compliance and willingness to continue was found to be more in the oral group. And the abortion and miscarriage rate was also similar. It was not very significantly high as and in all 3 groups we studied.
Was there a difference between a group which stopped at 20 weeks and the one which continued at 32 weeks? Was there a difference?
Amila, here I would say there was only one patient who did not want to continue out of the 150 women. And I think it's also the psychology of a patient who has a risk factor that if you tell them that there is this option, we had a proper detailed, Hindi, Marathi information sheet. So they said, why not? If, we can continue it, and it was coming free to them. But we did find, now I feel we need to compare it with people who are getting placebo to really know whether that prevention of preterm labor is partly placebo effect or whether it is, we can strongly say that progesterone definitely reduces the risk of preterm labor, which has been suggested by certain Cochrane reviews, which is why we did this as a long-term study till delivery.
You didn't compare with IM progesterone because FDA is issuing a warning now not to use IM.
No, we didn't use IM progesterone at all in any of the groups.
Because America has been using IM progesterone as their agent for prevention of
yes, but Sharmila, most of the evidence from Europe and the US is actually showing that intramuscular does not give any advantage in view of pharmacokinetics and otherwise. So in fact, in this American Journal of Perinatology, we have a pharmacologist who is also on the National Pharmacovigilance Committee. And she has reviewed, and her review of articles also suggests that intramuscular preparations are not giving any advantage to either the vaginal or oral route based on what are the other factors in the patient.
The NEGM article which came as a rebuttal to that, they have said that the comparison was between the white group of America with the black group, because the black population is the one which has the highest incidence of preterm labor. So when they did the second phase of the study, it was done in Europe where all white women were enrolled. So they said the difference matters because black people have had a benefit with IM progesterone. So why do you want to stop a drug which is really working in a group of population? Probably there's a subgroup which benefits with IM progesterone also. So maybe
I think maybe we need larger studies in our country, and maybe the clinical research committee of Foxy or somebody else can also take this up to compare the intramuscular and the other routes. That would also be a good idea.
But a real initiative, because we have got some Indian data to tell us that we can
Thank you so much. It was very difficult actually to convince the ethics committee to allow this, but I'm glad we managed to get through with it. Thank you.
Congratulations, Dr. Reenamani.
Thank you very much, Dr.
Great start.
Thank you.
So thank you, Dr. Bhumika.
Congratulations. Thank you. And just to answer Dr. Alka, the sedation and giddiness is the oral preparation, which is there's an immediate absorption of almost 80% of the progesterone.
Yeah.
Sustained release, it is initially only 40% gets absorbed, and then there's a gradual absorption. With the sustained release, there is very much, I think it's just some 0.6% of giddiness which is seen. The advantage of the sustained release.
Yeah. Most of them present with this. That's why
Yes, correct. Absolutely right.
So all in all, basically, we would now we can, from this study done, we can definitely promote oral NMP-SR for our patients who, especially the people who are asking that we don't want to take vaginally, we are not comfortable because many times we keep insisting that we will have more side effects, this, that. So of course, more studies will definitely, in fact, we should also participate in studies so that we come more data. Thank you, everybody.
So thank you.
Thank you.
Thank you.
Thank you.
Thank you, Dr. Bhumika, for enlightening such a wonderful topic, which is
Thank
so
you,
much
ma'am.
debatable. So thank you.
Thank you so much,
On behalf of
Dr.
myself and Dr. Alka Godbole, I thank the Mumbai Obstetric Gynec Society and ISOPAR Mumbai chapter. Thank you very much.
Thank you. Thank you.
Thank you so much, Dr. Alka, Dr. Rakesh Pandya, Dr. Bhumika,
Thank
and
you, Dr.
Shreya
Rakesh
for
Pandya
sitting with
and
us.
Dr. Alka Godbole, madam, for chairing this session so beautifully. And thank you to the speakers,
My pleasure.
Dr. Bhumika and Dr. Shreya. Thank you.
Thank you so much for such an amazing academic session one. Now, I would love to invite the young, dynamic, and gorgeous fellow MOC for the day, who's Dr. Amity Agrawal. She's a fertility consultant and medical director at Sunshine Fertility and IVF Center, Mumbai. And the latest award in her kitty is the Midday Youth Icon Award. She won it in the category of IVF Youth Icon Award just a month ago. I would love to invite Dr. Amity Agrawal to carry on this amazing program forward. Dr. Amity Agrawal, over to you.
Hello. Hello.
Yes, Dr. Amity, we are able to hear you.
Am I audible?
Yes, a little more louder.
Yeah. So, very good afternoon to everybody, all the respected speakers and the amazing faculty. And thanks a lot to MOGS for having us on board to conduct this beautiful session in the morning. And it's indeed a fabulous academic feast. The speakers have been phenomenal. My dear friend, Dr. Shreya and Dr. Bhumika have been really, really good. And thanks a lot, Reena ma'am, for giving us a very, very good insight about the whole use of progesterone during pregnancy. Now, moving forward, we will go on to the second session. So I would like to introduce the chairpersons. Can I have the slide, please? I would like to invite Dr. A. Charmila ma'am. She is the chairperson of the Clinical Research Committee, FOXY 2016-2018 to 2018. She's the president of Menstrual Hygiene Management Consortium. She's the director of Aditi Hospital and Parvati Ayavu Fertility Center in Trichy. She's a consultant to Southern Railway Hospital, Trichy. She's been awarded for standing first in DFP. She's the past secretary of Trichy Obs and Gynae Society. She's the organizing secretary of FOXY South Zone 2013. She has won 5 trophies of FOXY as secretary of Trichy OG Society. She's also been awarded the Mehru Hensotia Prize for committee work by FOXY 2018. She's the editor of Handbook on RPL and ICOG campus on high-risk pregnancy. I warmly would like to welcome you on board, ma'am, to chair this session. Also, we have our very sweet and very dynamic Rajendra Nagarkatti sir, and he's the chairperson of FOXY Midlife Management Committee. He's the chairperson of MOGS Midlife Management Committee, executive council member of MOGS, founder secretary of ISOPAB Mumbai chapter. He's the past president of the AFG Mumbai, joint treasurer of AMC Mumbai. He's the past president of IMA Meera Bhayandar branch. He's the past president of Bhayandar Medical Association, and he's a consultant at Ashirwad Maternity and General Hospital in Bhayandar. He's also a consultant at Wokhad Hospital, Meera Road. And he's an IVF consultant at Profert IVF Center. A very, very warm welcome to you again, sir. Please chair the session.
Thank you so much, Raj, the sweet Raj, as she said, for the opportunity. And it's a great honor to be with MOGS because it's my parent place, Bombay. I was a member of the MOGS before I moved on to Trichy, and it's a great honor to be with all my friends here. And I'm extremely pleased and honored to introduce a great stalwart of FOXY, Dr. Krishnendra Gupta, to this audience. May I have his CV, please? Sir is a professor and unit head, Department of OBGYN at Vivekananda Institute of Medical Sciences, Kolkata. He's a professor, is an adjunct professor to Mahe Manipal from 2017 to 2022. He's a FOXY representative to the Asian Oceania Federation of Obstetrics and Gynecology till 2022. He's a chair of the Sexual and Reproductive Health Committee of AOFOG. He's a president of the Bengal Society in 2013. He's been the chairperson of the ICOG in 2016. He's been the vice president of Foxy in 2011, the president ISOPAB 2015 to 19, chairperson of the Reproductive Endocrinology Committee in 2003 to 2007. He's been an editor of the national corresponding editor for Jogi in 2014 to 16. He's an honorable referee of the Journal of Indian Medical Association, and he's an examiner for so many colleges. I would like to welcome Sir to this program, and this topic will be on PPROM, the current thoughts and concepts. And we know that anything which causes a breach of the membrane is going to cause a premature rupture of membranes. And in spite of having so many modalities, still we are left sometimes, we are flabbergasted with the way it behaves, because we don't know, even with the suture, even with this, all the cocktail of progesterones, still people have a leaking at preterm. And the burden of preterm labor in our country is really huge. I would like to welcome Sir to give us thoughts on the topic, and hopefully we'll get some take-home messages, because he always gives us great messages. Welcome, Sir.
Thank you very much, Dr. Charmila, for this very generous introduction. And I take this opportunity to thank Dr. Rishma Pai, Dr. Anahita Chauhan, and the entire team of MOGS, and of course, our past president of FOGSI, Dr. Suchitra Pandit, and Dr. Rajendra Nagarkatti, and the team at ISOPARK for this wonderful opportunity. We are really running a bit late, so I'm going to get cracking on my presentation. I hope my slide is seen and I'm seen too. Can I be heard?
Yes, sir. Yes, audible, yes. And right, very much lovely. Visible, sir.
Right. So let me start with this statement that preterm labor, PROM and PPROM are perhaps amongst the more common and easily preventable causes of perinatal mortality and morbidity. And to just give you some facts about PROM, which is premature rupture of membranes or pre-labor rupture of membrane, it refers to the rupture of membranes before the onset of labor. The incidence is about 10% of pregnancy. So we have term PROM and of course PPROM, which is the actually focus of my presentation. Term PROM is more than 37 weeks and PPROM is less than 37 weeks. The incidence is about 3% and it's responsible to 30 to 40% of all preterm births. Now there's some important definitions which we must remember. One is low birth weight, which is neonates weighing between 1,500 to 2,500 grams. Very low birth weight, which is neonates weighing between 1,000 to 1,499 grams. Extremely low birth weight, neonates weighing between 500 to 999 grams. Now, way back in 1960, the risk of death of a baby weighing 1,000 grams at birth was 95%. And just see the reversal, that beyond 2007, because of a fantastic neonatal setup, the infection control, the survival is more than 95%. Now, why is it so important to know these definitions? It's not for theory. It's because these very low birth weight infants have got problems. They have problems with organ and organ systems, which are both short-term and long-term. And in any standard textbook, you'll find these. The organ systems involve the pulmonary system, the GI system, the immunological system, the CNS, which is extremely important, the intraventricular hemorrhage leading to cerebral palsy. I'm going to deal with that later. Ophthalmologic problems, cardiovascular problems, renal problems, hematological problems, and finally, endocrinological problems. So there's a whole gamut of problems which this very low birth weight infants, kind of go through. I'm also aware that a large number of practicing gynecologists and postgraduates are logged into the webinar. So therefore, I'm going to give you an overview of the entire presentation of PPROM. Now, what's the pathophysiology? We know that the fetal membranes are composed of the amnion and the chorion bound together by the different layers composed of the extracellular matrix. Now, the matrix is a very, very important, the key factor for elasticity and tensile strength of the fetal membranes. And any process that weakens the matrix increases the chance of rupture of membrane. So mechanical factor, which can cause distension, over-distended kind of uterus, as we see in multiple pregnancy, etc., which I'll come to. So what are the risk factors? Infection is the greatest risk factor. Previous history of PROM, the recurrence rate is as high as 20%, 21%. Antepartum hemorrhage, multiple pregnancy, polyhydramnios, smoking, drug abuse. We know these kind of recreational drugs which are being used now, heroin, etc. Cervical insufficiency, which of course Charmila was referring to about putting the stitch, etc. Iatrogenic, cerclage operation, amniocentesis, and of course fetoscopy. But as I said, infection is the most important factor. So it is because of these bacterial proteases which decrease the strength and the elasticity of the membranes. And these bacteria produces phospholipases, which stimulate the release of prostaglandins, from arachidonic acid, leading to premature uterine contractions. And they cause host immune responses, releasing cytokines and mediators, which cause weakening of the membranes, damaging this so-called matrix, and releasing what is called as the matrix metalloproteinases, which are a family of enzymes which are released from the extracellular matrix and also decrease membrane strength by increasing collagen degradation. So increased risk of PPRM is also seen in women with the group B streptococcus, the GBS as we call it, Streptococcus A galactae, as well as the Gardnerella vaginalis. And of course, gonorrhea, trichomonas, and chlamydia also play a big role. Now, the issue is the clinical infection is about 1 to 2%, but it is the subclinical infection which causes the problem. You don't know that the lady has it, but if you don't treat these subclinical infections, you're going to land up with a PPRM and the sequelae of all the problems. So how do we diagnose? I think all of us know that. History of leaking, of any like per vagina, per speculum examination, the Valsalva maneuver. We, of course, avoid doing any vaginal or digital examination. And of course, biochemical tests, which we all know for theoretical purposes, like the nitrogen paper test, Fern test, Nile blue test, other tests like indigo, carmine, to just write a lovely long answer question, detection of fetal fibronectin, but something called as the amniosense test, which kind of is a kind of a strip with a medicated kind of a strip here. If the color changes and it's persistent, the color persists after drying up, then you know it most likely is liker, while if it goes back to the colorless situation, it is definitely not liker. And this was a kind of a very good test with a high degree of sensitivity. Of course, the ultrasound, we know the role has been discussed a lot. The amniotic fluid volume, the assessment of the cervix, again, whether you want to put the stitch or not, whether there's any funneling, assessment of the fetus, and of course the placental localization, because we know that abruption is one of the causes is one of the problems which can be there because of PPROM. So what are the maternal complications? We know chorioamnionitis, puerperal sepsis. We know the definition of chorioamnionitis. I'm not going to really go on to it, but abruptio placenta as high as about 4 to 12%. And of course, the increased incidence of cesarean section, which is important. The fetal or neonatal complications, I'm going to stress a lot on that. Prematurity, infection, neonatal septicemia, fetal asphyxia, then fetal pulmonary hypoplasia, musculoskeletal deformities, and of course, respiratory distress syndrome and the dreaded cerebral palsy. And that is what is extremely important for us to remember. Now, what was the early observational data which actually made us think that magnesium sulfate will actually work? In 1980, studies showed that there was a decreased rate of intraventricular hemorrhage and cerebral palsy in very low birth weights infants born to women with preeclampsia. And it was also shown that very low birth weight infants exposed to magnesium sulfate for tocolysis had decreased rate of intraventricular hemorrhage. And it was also seen that lower rate of cerebral palsy in very low birth weight infants exposed to magnesium sulfate in 1996. And you know that the rate of the baby is dying less than 1,000 grams those days was 95%. So this was the thought process that if we can expose these kind of very low birth weight babies, fetuses to magnesium sulfate, whether it will help. So this led to the antenatal administration of magnesium sulfate in imminent births, which protects the offspring from the risk of cerebral palsy. And by imminent birth, I mean preterm labor with or without PPROM and planned preterm birth for fetal or maternal infection. So how does it work? It works in one of 4 ways. Basically, magnesium sulfate reduces neuronal injury by downregulation of excitatory stimuli. These damaged neurons are sensitive to the excitatory neurotransmitter glutamate, but by blocking this NMDA receptor by magnesium, it prevents the influx of calcium that causes cell death. So this is one mechanism. The other mechanism, it has the vasoactive properties of magnesium may result in increased cerebral blood flow due to cerebral vasodilatation, thereby minimizing the hypoxic ischemic change. Thirdly, there's a reduction of both oxygen-free radicals and pro-inflammatory cytokines with magnesium sulfate administration, and which can, which kind of prevents neuronal injury. And finally, magnesium may have anti-apoptotic or programmed cell death effects, thus directly reducing neuronal loss. So given the varied pathophysiology associated with preterm birth, it is likely that one or more of these mechanisms may be responsible for neuroprotection in any given clinical circumstances. So it imparts best protection when it's given between 24 to 32 weeks of gestation. And the dose is, of course, 4 milligrams IV loading dose over 30 minutes, followed by 1 gram per hour maintenance infusion until birth. And for planned preterm birth, it is ideally started within 4 hours before the birth, given as a 4 gram IV loading dose over 30 minutes, followed by 1 gram per hour maintenance dose until birth. An often asked question in the exam for postgraduate is what I'm going to come to very soon, that it should be discontinued when there is no delivery imminent or a maximum of 24 hours of therapy is given. And it is given for neuroprotection. When given for neuroprotection, you actually do not need any other tocolytics because magnesium sulfate itself is a tocolytic. So how do you administer it? The loading dose, as I said, is 4 grams. So 1 ampule of magnesium sulfate contains 1 gram in 2 mils, which is a 50% solution. Often asked question in the exam. So initial 4 grams IV over 30 to 60 minutes. So what you do is you dilute 4 ampule of magnesium sulfate, that's 8 mils. You add 12 mils of normal saline, make it 20 mils, infuse 20 mils in 30 to 60 minutes. I think my slide is worth it with Raju taking a picture of it. Maintenance, 1 gram IV per hour for 24 hours. So you dilute 10 amps of magnesium sulfate, 20 mils, you add 30 mils of normal saline, make it 50 mils, and you infuse 5 mils per hour for 24 hours. So this gives you an idea that how you should give the loading dose, how you should give the maintenance dose, and check for any signs of magnesium toxicity, which is beyond the scope of this presentation. It all started with this Cochrane database. It's a very busy slide, I know, but just to highlight, in 2009, it was proven without doubt by all the systemic reviews that magnesium sulfate definitely helped for neuroprotection of preterm fetuses. Then came out this wonderful kind of committee opinion in 2010 by the ACOG in number 455, which has been reaffirmed in 2020. So actually nothing has been changed word for 10 years. Can you imagine how beautifully it was drafted in March 2010 that was just reaffirmed in 2020? Then came another wonderful study of what is called a scientific impact paper from the RCOG, paper number 29, which again clearly showed that it reduces the risk of cerebral palsy and protects gross motor function in those born preterm. So therefore, there's a definite use of magnesium sulfate. Thereafter, a study came out in Cochrane because people started giving magnesium sulfate even for fetuses at term. No, it is shown that there's insufficient evidence to show that neuroprotection of the term fetus is given by magnesium sulfate. So it's very good, solid data for preterm, but not for term. A lovely clinical guideline from the RCPI in 2015, that's the Royal College of Physicians of Ireland, from the Institute of Obstetrician and Gynecology, came out of the antenatal magnesium sulfate for fetal protection. And of course, the point which was very much discussed is about the antibiotic regimen. There's no clear-cut guideline, but one thing is for sure, that you must avoid co-amoxiclav. We give it left, right, and center because it should be avoided in women with risk of preterm delivery due to the increased risk of neonatal necrotizing enterocolitis. So co-amoxiclav is definitely one of the antibiotics to be avoided. And the antibiotic of choice is, of course, erythromycin, which I'm going to come to a little later. A wonderful study in the Annals of Pregnancy and Birth by Karamangulu was published in 2018 regarding chorioamnionitis. Here, the main latency period was between 5.7 to 6.2 days after rupture. And it was found that the less advanced gestational age, higher values of initial leukocyte and CRP, and lower levels of initial AFI were associated with the risk of chorioamnionitis. And prolongation of latency periods increased the risk of febrile morbidity. The most common neonatal morbidities were respiratory distress syndrome, hyperbilirubinemia, sepsis, the biggest killer, congenital pneumonia, and of course, the neonatal mortality rate was as high as 6.7%. So the authors concluded from this study very beautifully that it is the prediction and the diagnosis of the maternal and neonatal complications are crucial in women with PPROM. A wonderful review article on PPROM by Chirekov et al. In the Journal of Perinatal Medicine in 2017. It's a must read if you want to prepare any presentation or you want to take an exam, you get a long case of PPROM. This is the one to read, other than, of course, the latest green top guideline from the RCOG, which I'm going to come to later on, where they gave an exhaustive kind of comprehensive review of all the colleges, the American College, the German College, the RANSCOG, that's in Australia, New Zealand, RCOG, the SOCG from Canada, about all the antibiotics. It's a very busy slide, I agree. But the one which they have which is very common orally, is that you must give erythromycin, which is not very commonly, unfortunately, not very commonly given in our country for whatever reason. Erythromycin is an extremely important drug, less use, less amount of resistance, and it's a must give in this. A lovely Green Top guideline in 2017 came out about the prevention of early onset neonatal group B streptococcal disease. And here, what was very important for PPROM is that the group B streptococcus carriers have preterm rupture of membranes. Women who have that, they must be treated, because otherwise you're going to end up with a problem of rupture of membranes, even those who have a kind of, you have not yet treated the problem and they are positive for the disease. So this is a very, very good paper, which you must kind of read as far as group B streptococcal disease is concerned. Another very good guideline from the RCPI in 2015 regarding preterm pre-labor rupture of membranes, PPRM, and this one is undergoing review. So it's no longer available on the site. It is going under review, because I had a word with one of them since I know the person. It is under review and should be out hopefully by this year end. And of course, the wonderful, wonderful Green Top guideline from the RCOG in 2019, where the care of women presenting with suspected preterm pre-labor rupture of membranes from 24 weeks onwards till of gestation till the 36 weeks. So coming to the management, of course, it depends on the gestational age. And it's very clear that if it's more than 34 weeks, you proceed to delivery. Group B streptococcal prophylaxis is recommended. In our country, we are extremely pro to give corticosteroids. 32 to 33 weeks, of course, expected management. We try to delay as long as we can. We give the group B streptococcal prophylaxis. Corticosteroids, definite consensus in our country for sure that we must give it. And there's no question, because the people in the UK and US and other countries are extremely happy to deliver the baby at 32 to 33 weeks, because they have extremely very good kind of neonatal setup, which of course, which only available in very, very big cities and big centers in our country. 24 to 31 weeks, of course, again, it's a huge problem for our setup here. We have to give the corticosteroids which are recommended. Tocolysis, of course, there's no consensus. Antimicrobials, definitely we must give to kind of prevent all the sequelae of the PPROM. And the combination of birth weight, gestational age, and sex provides the best estimates chances of survival and should be considered in individual cases. But I think in all these kind of 24 weeks, less than 24 weeks, about 30 weeks, patient counseling, that emotional support is extremely, extremely important to take care from the doctor point of view, because their expenses are going to be high. You must understand, just taking out the baby is no big deal. The cost, the neonatal setup cost, is going to really drain the family. So they must know you may protect, you may do neuroprotection, but the cost is going to kill them at the end. And that is what is the most important point. So this is, of course, a very busy slide, more for taking a postgraduate lecture, but for the postgraduates present, this is an algorithm which you must follow, simple, and if you can take a screenshot, well and good. That's why I'm just keeping it on for a few seconds. And it's a very, very beautifully kind of a algorithm to treat PPROM. So I'll end with the recommendations from the Green Top guideline in June 2019, where it clearly shows that the diagnosis of spontaneous rupture of membranes is made by maternal history, followed by sterile speculum examination, rather low as far as the grading is concerned, grade D. If on speculum examination, no amniotic fluid is observed, clinician should consider performing an insulin-like growth factor binding protein 1 or a placental alpha microglobulin 1 test of the vaginal fluid, which is quite impossible in our country at this point of time. This is again a lot of theoretical stuff and practical, where you can afford these kind of tests. I think in a routine setup you cannot. Following the diagnosis of PPROM, an antibiotic, preferably erythromycin, should be given for at least 10 days or until the woman is in established labor, which is sooner. Grade A, very, very good recommendation. Women who have PPROM between 24 and 33 plus 6 weeks of gestation should be offered corticosteroids. This is a must. Steroids can help and can be considered up to almost 36 weeks of gestation. Again, very strong evidence, grade A. A combination of clinical assessment, maternal blood tests like C-reactive protein, white cell count, fetal heart rate should be used to diagnose chorioamnionitis in women with PPROM. These parameters should not be used in isolation. It's no use if you use them in isolation. Again, a grade D recommendation. Women whose pregnancy is complicated by PPROM after 24 weeks gestation and who has no contraindication to continuing the pregnancy should be offered expectant management until 37 weeks. Timing of the birth should be discussed with each woman on an individual basis with careful consideration of patient preference and ongoing clinical assessment. Very, very strong recommendation. In women who have PPROM and are in established labor or having a planned preterm birth within 24 hours, intravenous magnesium sulfate should be offered between 24 and 30 weeks of gestation. Of course, in our country, it is beyond that because we are scared to deliver the baby even at 30 weeks. So there's a lot of difference. You have to also see where you are practicing. If you're practicing in the suburbs, obviously beyond 32 weeks, you're going to give corticosteroids. You can't just say that this guideline says at after 30 weeks. No, we have to give it because we have to give it as per where we are practicing. So what are the points to remember? PPROM complicates up to 3% of pregnancies and is associated with 30 to 40% of preterm births. It can result in significant neonatal morbidity and mortality, primarily from prematurity, sepsis, cord prolapse, and pulmonary hypoplasia. In addition, there are risks associated with chorioamnionitis and placental abruption, increased rate of cesarean section rates as well. The median latency after PPROM is 7 days and tends to shorten as the gestation age of PPROM advances. So to summarize, it's a major public health problem. The healthcare costs, both in the developing and developed countries because of this issue of PROM and PPROM is tremendously high. It directly contributes to 75% of neonatal mortality and 50% of long-term neurological impairment in children. It accounts for 35 and 10% of healthcare spending for infants and children. So it's a huge economic burden, and that is why counseling, emotional support is so important. But what is so unfortunate is that the incidence of preterm birth has changed vastly over 40 years. What has changed is our method of treatment. Our setups have improved, but we have not been able to prevent preterm labor. And it's widely recognized that this prevention of preterm labor will prevent PPROM and PROM, and with effective management, we will improve the neonatal outcome, which will have a profound impact on societal and long-term public healthcare costs as well. So the take-home messages are, 1, identify potential risk factors of PPROM, avoid co-amoxiclav, and never, ever forget fetal neuroprotection with magnesium sulfate in preterm babies. This is extremely important. Confucius said, I hear and I forget, I see and I remember, I do and I understand. And it is our job to ensure that we do enough for fetal neuroprotection in PPROM. Thank you very much for your patient hearing. Hopefully I stuck within time, and I hope that I could send some kind of message, some overview. It cannot be a full presentation. It's a huge topic, but I hope I've been able to give you a gist, an overview of the problem of PPROM, what to read for further reading as well. Thank you very much for this opportunity. I'm extremely grateful to all of you for your patient hearing. Thank you.
Thank you, sir. It was a wonderful and it's a very comprehensive talk, which you could do in such a short period of time with great take-home messages. I'd like to just ask, suppose you need to give repeated dose of steroids if she does not deliver within that 34 weeks. So you're given one shot.
Two is enough.
2 is enough. You do not repeat.
I don't repeat. I don't know what the others are doing. Maybe Anahita, Reena, Sarita can chip in. Professor Saraugi is there. My God. Bipin. I just saw Professor Saraugi. Namaskar, sir. Arun is there. Ashok is there. My God, the entire gamut. All. So I think you can tickle their brain in this. I give only 2 and stop there. I don't know what the others do.
Sir, good morning, sir. Dr. Krishnendu. This is Dr. Vijay Lakshmi.
Yes, hi Vijay Lakshmi.
Hi, sir. It was a very nice talk as usual. So, with permission of the chairperson, Charmila and Rajendra, can I ask him a question?
No, this question we wanted an answer, ma'am.
Yeah, repeat. I have answered. I give 2. Others, Reena, please.
Krishnendu, very important message which you have given is not to use amoxiclav, because a lot of people were using it left, right and center as the most easily available antibiotic, and evidence from RCOG was presented beautifully by you. And about the 2 doses of steroids, again, especially for PPROM, they say that just 2 doses are enough, because giving repeated steroids may increase the risk of infection in the neonate, and that is also a concern. So I would go with what Krishnendu said, and most of us are not using what they call as rescue steroids or repeating it in case the labor is prolonged. What you had given at the outset is more than enough.
And regarding, suppose that you have put a suture and she leaks in spite of that, and you remove that suture, or you leave it behind.
So if
she's not in
leaks
labor
and delivery is imminent,
You
I
have
think
to
we
remove
would
it.
remove. Krishna,
Otherwise, you'll have an annular detachment of the cervix.
Even
Nice,
if she,
nice little vada you will get. This is a joke by one of my professors. They always used to say, "Please remember to remove it," because I was trained in South India, so it's very.
So actually, there's one IVF center here. They were asking a question like, they give all the masala. They give probiotics even before they do the embryo transfer, and then they give probiotics once the second trimester starts. They put a cervical suture, give all the progesterones. But she said she has had a high incidence of PPROM at 20 to 22 weeks of gestation in the last since COVID started. Is there a correlation somewhere? They've done everything possible. And I told her actually
a lot of problems. Everybody links COVID into the question, which is actually nothing to relate it with COVID.
So actually, I told her stop.
The moment the word COVID comes, you get scared what to answer because you don't know. Basically.
No, that's what she was saying. It seems they have a general protocol of doing all this for their IVF patients, but still they had a big group of people who had leaking around 20 to 22 weeks of pregnancy. So she was asking. So I told her stop all the masala. Probably with a simple treatment, over treatment could have been the cause. That's what.
Dr. Vijay Lakshmi wanted to ask a question.
Yes, ma'am.
No, sir. Actually, suppose the patient has a high leak and she goes in for high membrane leak. The flat membranes are there on examination. Patient is going to go into labor or we have induced or whatever. Does it matter that membrane layer is kept, or is it okay even if we do the rupture? Because the pediatricians often say if there is a barrier, let it be there from the neonatal infection point of view. So is there any study or something like there is a flat membrane, but there is a high leak posteriorly?
It all depends what is the level of your amniotic fluid. So
if AFI is
high leak and it closes on its own, and if the AFI is more than 5 or something like that, then I think we can definitely wait. I think, and that is what I don't know whether we were postgraduates.
I'm talking about the membrane getting
I'm just it all depends on the period of gestation also, right? What is the period of gestation? Suppose it's a high leak at 34 weeks or 32 weeks. Why I'm repeating this is because when we were postgraduates, the moment we gave magnesium sulfate for threatening eclampsia, I'm not anything to do with PPRM. We thought that we are committed to deliver the baby.
Yes.
The patient could not go back to the ward. But now it's not like that. We are giving magnesium sulfate for neuroprotection. And if it's a high leak, the leak stops, we continue the pregnancy. It's not that just because we have given magnesium sulfate, we have to deliver the baby. So here, it all depends your period of gestation, the amount of fluid which is there, by ultrasound, and you have to monitor her now, because how high leak, a lot of small micro leaks, high leaks can kind of heal by itself. But if there is persistent kind of leaking, then of course, as Reena said, we cannot do anything.
So one question, since you're on AFI, if you're waiting for that this of gestational age of 32 weeks or so, up to what level of AFI would you wait if the blood flow is normal? If the blood flow
there is a role of amnio infusion. Of course, I did not touch upon. I mean, as Reena said, there in the latest Green Top guideline, there is a very, very important point. What is the role of amnio infusion? The amnio infusion is definitely there. There is a thought process. Then, as you said about AFI, I think the cutoff is between 5 and 7. If it becomes less than 5, and if it's around 7 to 10, we are kind of, we are happy. And then you're also doing Doppler studies, to see. I mean,
so if the Doppler is normal, but if the AFI is less than 5, then you still need
So you see ductus venosus,
right.
Ductus venosus flow is very important there. But if ductus venosus flow, there's a problem, then deliver the baby.
Okay.
Reena, please correct me.
Dr. Ashok Kumar wants to say something. Yeah.
Ashok sir wants to say.
Ashok.
Thank you, Dr. Krishnendu, for your excellent talk as usual, with full of information. But I will just try to add one more thing which you have highlighted. This is just for the PGs, because you told that for amniotic fluid, if we are not getting anything on the per speculum examination, then sometimes it becomes very difficult to confirm whether it is a PPROM or PROM or not. And we have to make a diagnosis with all those new commercially available kits, which might be costly and may not be available everywhere. So for postgraduate, I think we should not forget about bedside tests, which are easily available to diagnose PPROM or leaking of amniotic fluid by like the pH of the fluid which is coming out, or we used to do microscopic foreign test, or so many things which we used to do. So I think that is also play a very important role, and we should adapt to our local situation if the things are not available.
No, of course, I totally agree, Ashok. But see, when you give a presentation for the postgraduates, I'm going to deal with the 9-blue sulfate, no. Much more larger. But here, when you are already running a bit late and given 20 minutes, you have to give it is just a ticking of the thought of the postgraduates.
I'm just reminding them.
No, I agree. I totally agree with you. I totally agree.
And second, about the steroid dose, I think I also follow the 2 doses, then there's no repeat.
There's only one thing which may, because steroids is an important point, is a lot of the time this betamethasone is not available.
Yes.
Then you have to this DEXA, and DEXA is 6 milligram or 8 milligram 3 times, and 6 hourly the patients are cribbing with because it's not easy to, because 6 hourly administration, 8 hourly. So betamethasone had the best 112 hourly, so there was no problem. So this is where I think the postgraduates also will have to, that both are good, betamethasone and dexamethasone, although something came out about betamethasone in the middle, and then there was a big debate about it. But I think both are safe, and you must give. That is more important. Remember to give it.
So anything to prevent cord prolapse, because with the leaking, you've got a high risk of cord prolapse there.
Charmila, that is the inherent risk. That is the inherent risk of this problem.
How to prevent? You have to see.
Any bed rest, something, because many make them sleep all upside down and all that.
Professor Saraugi, is there any comment from Professor Saraugi? Is always welcome. Because
Sir, I believe in giving rescue dose, particularly if PROM or PPROM has occurred about 2 weeks and I have done conservative management. And if they go in labor after 2 to 3 weeks, I believe in giving 1 rescue dose. And I have found good results with that.
So what is the dosing you give? 8 milligrams?
8 milligram, that's all.
Okay.
Single dose.
No, or will you give a 12 milligram, depending on what you're using?
No, generally we use 8 milligram. 1 single dose, that's all.
Okay.
And sir, one question is, we know that Gardnerella is known to cause, chlamydia is known to cause PPROM. How do you diagnose that? We don't do PS or PV examination of each and every pregnant patient. Now, do you want to give drugs just like that, or you would like to do PS and PV every time the patient comes in ANC?
So the only other way is a high vaginal swab, and
so every time you can't do
trachomatis, it's difficult to it's quite difficult to.
We know that it's known to cause PPROM.
So
but
we are giving prophylactic antibiotics. What else to answer? What we are doing, we are doing. We're not repeating for the kind of tests.
Should we keep giving the doses again and again? Maybe every month.
Arun sir wants to answer.
Yes.
Arun sir.
Arun.
Sir, you have to unmute yourself, sir. Please unmute yourself.
Arun, please unmute.
Yeah, I think a lot of papers have come up which say that asymptomatic bacterial vaginosis, there is no need to treat them. Like Krishnendu mentioned, that few papers have mentioned asymptomatic are the one which they are prone to develop PPROM. But a lot of papers are available where they say that asymptomatic we need not treat. And whenever patient has come with symptoms of discharge, foul smelling, the patients where we can do a swab, pick up the infection, and then at least those patients we should be treating.
Yes. So
we can move forward.
Yes.
Yeah.
Thank you so much.
Thank you
sir.
very much for the opportunity again.
Very nice.
Thank you, sir. Wonderful
talk, sir. Wonderful talk, sir. Yeah, we gained so much from that. Thank you so much. Thank you, Dr. Rajendra, for giving me this opportunity, as well as Dr. Komal. Thank you so much.
Thank you. So moving ahead, I think we'll go on to the next talk in this session, which is none other than by Professor Dr. Ashok Kumar. May I have his slide, please? Hypothyroidism in pregnancy, as we all know, can have a deleterious effect on the pregnancy, including risk of miscarriage, premature births, and even stillbirths. And not only the adverse fetal outcomes, there can also be adverse maternal outcomes that are possible. A role of antibodies, positive antithyroid antibodies, etc., also needs to be considered. And to hear about all this, we have none other than Professor Dr. Ashok Kumar, who is a professor director at the Atal Bihari Vajpayee Institute of Medical Sciences and the Dr. Ram Manohar Lohia Hospital, New Delhi. He's done his MD from the reputed All India Institute of Medical Sciences, New Delhi. He's done his PhD from the Tokyo Women's Medical University. Today, most importantly, he's the secretary-elect of the ICOG 2021-22. He's been a member of the governing council of ICOG from 2018 to 20, and he's also an editorial board member of the Indian Journal of Medical Research and Archives of Gynecology. So it would be a pleasure to hear from you. Over to you, Dr. Ashok Kumar.
Please allow me to share my screen.
Yes, sir.
Sir, you can share your screen now. Yep.
I think now is it visible, my screen?
Yes, sir.
Yes, sir. Yes, sir.
Okay. So at the outset, good morning and good afternoon, and thanks, Dr. Rajendra Nagarkatti, for inviting me for this opportunity. Thanks to MOGS and ISOPAR Mumbai chapter for this wonderful session on so many high-risk situations in pregnancy. And I straight away start with my topic, hypothyroidism in pregnancy. Actually pregnancy in hypothyroidism is very, very uncommon because mostly they are anovulatory. And if they conceive, there is very high risk of spontaneous abortion. Then there is a problem of subclinical hypothyroidism also, which is around 2 to 2.5% of pregnancy. And the welcoming part is that perinatal outcome is becoming favorable now in this situation because of the advancement. As we see, the prevalence and global or the Indian prevalence varies depending on the situation we take, whether we take overt hypothyroidism or subclinical hypothyroidism. But if we see the global data, and this is I am talking in reference to because we follow American Thyroid Association guideline, the data of subclinical hypothyroidism is 2 to 2.5% in US, which is an iodine sufficient region. This we have to remember because the data may be different from the iodine deficient areas. We have done study in our hospital where we found the prevalence of hypothyroidism is around 1.6%. Now, this wide variation is in prevalence of hypothyroidism between different countries and geographical areas may be attributed to differences in ethnicity, iodine status in that population, prevalence of thyroid antibodies, and different cutoff of TSH used. So we have to remember all these variation when we talk of thyroid or hypothyroidism. Then thyroid physiology also play a dynamic role during pregnancy to meet the increased metabolic needs. Therefore, it is now accepted that we should have population and trimester specific reference range for serum TSH. Now, there are various causes of hypothyroidism. It may be autoimmune, iatrogenic, congenital. Iodine deficiency is the commonest in our population. Diagnosis is usually made by measuring the thyroid levels, but symptoms may be non-specific. As we see, the classical symptoms are only present in 1/3 of the population who have abnormal TSH. Then 20% might be having only biochemical hypothyroidism, which they may be asymptomatic, and non-specific thyroid autoantibodies were positive in 20% of euthyroid pregnant women. So we have a lot of variation, and sometimes becomes very difficult to diagnose until we measure TSH or we do thyroid function test. There are few high-risk group in which we have to be having very high index of suspicion. They are previously treated hyperthyroid, previous head or neck irradiation, previous postpartum thyroid dysfunction, patient with goiter, patient is on antithyroid or some other drug therapy, which I will tell you what are those. Family history of thyroid disease, hypopituitary disease, or type 1 diabetes. All these may have high risk for hypothyroidism. And there are various drugs, if you see the list is long, which may interfere or interact and can cause hypothyroidism. Now, just a few words on the thyroid physiology in pregnancy before we understand hypothyroidism in pregnancy. There is increased estrogen in pregnancy, which increases thyroid binding globulin, and thereby it can lead to decreased free T4 and T3 levels, which are actually the working hormone. We have similar structure of HCG and TSH in pregnancy. HCG stimulates release of T3 and T4, and therefore this may temporarily decrease TSH level between 8 to 14 weeks of pregnancy. We have increased peripheral metabolism of T3 and T4. These are the hormones. And this decreases free T3 and T4 thyroxine levels. And this may stimulate greater T4 output from the thyroid gland in a feedback mechanism to maintain steady state. So these are the things which are working in the body. And simultaneously, we have growing fetus and then fetal thyroid physiology also. What is happening in pregnancy? We have increased GFR, we have increased maternal renal clearance, and we have fetal use in late pregnancy. This all decreases plasma iodide, and in a feedback mechanism, the thyroid size increases to compensate, and therefore we have increased dietary iodine requirement. So because of this, hypothyroid require additional 20 to 30% of thyroxine over non-pregnant thyroxine requirement. And it has been observed that if there is a maternal hypothyroidism during pregnancy, IQ of children is affected. So pregnancy is a state of relative iodine deficiency because of increased dietary requirement, increased transplacental uptake of iodine, and increased maternal renal clearance. And there is simultaneous placental inactivation of thyroid hormones by the type 3 deiodinase in second and third trimester. So there is a compensatory homeostatic mechanism which starts to play. And this is very important in our population. We always try to forget this mechanism while we manage these patients. So there is an increased thyroid iodine uptake. There is an increased synthesis of hormone, and there is increased thyroid gland enlargement by approximately 10 to 20%. So what all is happening in pregnancy? 10 to 40% increase in size of gland, depending on the area from where that population is coming, whether it is iodine deficient or iodine sufficient. 50% increase in the production of hormones, 50% increase in the daily requirement of iodine. So euthyroid women in the first trimester may become hypothyroid during later stages. So that we have to remember. So these are how the thyroid hormones are fluctuating. If we see T3, T4, T4 levels are more or less remain steady, but in the third trimester they fall. TSH level across the trimester increases. This we have done in a pilot study long back, where we have tried to define normograms for T3, T4, TSH in our Delhi or the northern part of India, from where all population was coming. And if we see, we have wide range of TSH from 0.5 to 7.6. So sometime in iodine deficient areas, 4 or 5 may not be the cutoff. We may have to be a little bit liberal in accepting the patient as a normal range or in a hypothyroid range. So if you see in the second and third trimester, TSH may increase as the pregnancy advances. So if we talk of now ATA guideline, American Thyroid Association guideline, they are now also emphasizing that we should have references as per the population and trimester specific. And if those are not available, we should use the cutoff of 4. And if we have TSH concentration more than 2.5 with antibody, TSH more than 2.5, one should evaluate for thyroid antibodies also. Indian Thyroid Society in 2012, I think it is quite old now, they also suggested that it should be 4. The cutoff should be 4 for our Indian population. Now, what are the complications of hypothyroidism in pregnancy? If we see their preeclampsia, prematurity, stillbirth, then we have fetal bradycardia, low birth weight, abruptio placentae, neonatal death. So these are there's so many malformations is not there. So hypothyroidism increases the risk of fetal distress in labor, low birth weight because of preterm delivery, preeclampsia, gestational hypertension, and placental abruption. These are all associated with hypothyroidism in pregnancy. Increased risk of stillbirth because of preeclampsia and placental abruption. Reduced intellectual in offspring because of hypothyroidism affecting the IQ in early pregnancy. No increased risk of congenital malformation, maybe congenital cretinism, and maternal postpartum thyroid dysfunction. I think this is another important entity one should be looking at. In first trimester, abortion, spontaneous abortion is very common, 60% in overtly hypothyroid, 70% in subclinical hypothyroid. Preterm birth, this is the latest study from JAMA 2019, which is a meta-analysis of data of 19 cohort studies. And it's concluded that risk of preterm birth was higher in women with subclinical hypothyroid compared with euthyroid. Low thyroid hormone concentration in early pregnancy can be associated with significant decrements of IQ of children. But this study, which has published in BMJ 2018, A1 longitudinal study of parents and children, they found no association between maternal subclinical hypothyroidism in early pregnancy and childhood performance on national curriculum test administered from ages 4 to 15. So one has to again review. But here the important thing to note that the median TSH in subclinical hypothyroidism patient was around 3.2. So there is a lot of data and lot of evidences which are coming up now about hypothyroidism and subclinical hypothyroidism in pregnancy. So adverse effect of overt hypothyroidism in pregnancy is established. However, adverse outcome of subclinical hypothyroidism in pregnancy are still not conclusively established due to conflicting finding in the literature. Overall, there is a suggestion to indicate a higher risk of pregnancy-specific complication like pregnancy loss, preterm delivery, preeclampsia with elevated maternal TSH level. And these complications are increased if there is a presence of higher thyroid peroxidase antibody levels. So how to go about this, how to manage these patients to prevent or decrease perinatal complication? So the main thing is early treatment and close monitoring to maintain euthyroid status during pregnancy. Now, again, just to follow these American Thyroid Association guideline about for the treatment of hypothyroidism, so simple is you have to treat with the L-proxil. But for treatment of subclinical thyroid hypothyroidism, there is some confusion and controversies how to go about. So treatment of subclinical hypothyroidism, if TSH is elevated, and antibodies are there. So you treat. TSH level is higher than 10, even if antibodies are negative, you have to treat the patient. Now they say, they use the word consider. Consider the treatment with thyroxine. If TPO antibodies is positive and TSH level are more than 2.5 but less than the upper limit, that means if we take 4. So if TSH levels are between 2.5 and 4 antibody positive, then you can consider treatment. If TPO antibodies are negative but TSH levels are between 2.5 and 10, between 4 and 10, then you can think of or consider treatment. But treatment is not recommended in antibody negative patient and with the TSH level less than 4. So these are the guidelines from American Thyroid Association. They say that before conception, we should have TSH level below 2.5, after conception below 2.5 in the first trimester, before or below 3 in the second and third trimester. Increase the dose of levothyroxine by 22 to 30% when you as soon as pregnancy is confirmed. Regular TSH monitoring every 4 weeks and around 30 weeks. And after delivery, again check for TSH at 6 to 8 weeks and then readjust the dose. But there are difference of opinion and there are other evidences and other recommendations like Endocrine Society, European Endocrine Society and some other authors. So just to summarize here, it says that you take into consideration past history of recurrent miscarriages also when the TSH levels are between 2.5 to 4. That means they are not in the clinical clear-cut range of more than 4 hypothyroidism. So in those situations, look for antibodies. If antibodies are positive, the previous history or the patient profile is also at high risk, then you may think of giving L-toxin. So these points I want to emphasize is by this chart that there variation in the approach to the patient. You can take into consideration patient profile and antibody status and see how precious is the pregnancy and decide upon the option of giving L-toxin. Now, when you decide for the L-toxin, initial dose is around 1.6 to 2 microgram per kg actual weight per day. So it comes out to be around 100 to 150 microgram between. You have to readjust the dose for elevated TSH every 4 weeks. And grossly, this is the rough guide that how to add or increase the dose of L-toxin. If your TSH is still elevated around 10, you add 50. If they're more than 10, you around more than 50. But if TSH remains more than 4 and less than 10, then you can add 12 to 25 microgram per day and monitor TSH every 4 weeks until it returns to normal. Once TSH is normal, you monitor TSH values less often, at least once in each trimester, as long as the dose is unchanged. But if you're changing the dose of L-toxin, then you have to again follow this pattern of doing TSH every 4 weeks. Make sure that calcium, iron, and so on is not taken along with the thyroxine. Thyroxine is advised to be taken as empty stomach, ideally an hour before breakfast. Now, when the pregnant woman is on thyroxine, she conceives, her pregnancy is confirmed, increase the dose by 30% as soon as possible when pregnancy is confirmed. And the simple way is that you increase the dose from once daily dosing to a total of 9 doses per week. That means you double the daily dose 2 days each week. And then once you have increased the dose, monitor TSH level between 6 to 8 weeks, 16 to 20 weeks, and 28 to 30 weeks if they are remaining in the normal range. Readjust dose accordingly. If there is a change in the dose, thyroid test should be measured 4 weeks later. The target is you keep the TSH at the lower end of the normal range and free thyroxine T4 levels within the upper third of the reference range ideally after adjustment for the trimester. And after delivery, reduce doses to pre-pregnancy level and major TSH at 4 weeks. Some people are not following this step of increasing the dose by 30%. So if that is not the option you are following, then you can straight away monitor the TSH level. And if you find there is a variation in the TSH level, then you can adjust the dose accordingly. Generally, if TSH levels are more than 4 with low free T4, you have to follow the full replacement dose, that is around 1.6 to 2 microgram per kg body weight per day. If TSH are more than 4 with normal free T4, then intermediate dose around 1 microgram per day is given. That comes out to be around 50 for our population. But if the dose TSH is below 4, 2.5 to 4, and if you decide to give drug, low dose, typically 50, or sometimes you may start with 25 also microgram, and then accordingly you monitor the TSH levels. The important thing one can also consider is that hypothyroid women should have their levothyroxine dose optimized prior to becoming pregnant, and they should have normal TSH levels before pregnancy. And they should have their thyroid function tested as soon as pregnancy is diagnosed, and one has to adjust their TSH level in the normal range. This is another strategy which is there in 2017. It has recommended treatment for all cases of overt hypothyroidism. So there is no confusion for overt hypothyroidism. This is a meta-analysis of 14 RCTs of approximately 2,000 women. And they observed also that treatment significantly reduced abortion rate, reduced the incidence of gestational diabetes and gestational hypertension in these pregnancy. So we have one side is a complication of hypothyroidism. Another, we have to confirm whether our treatment is going to basically reduce these complications, although it is normalizing the TSH levels, but whether actually it is working and reducing the adverse effect. Yes, levothyroxine in overt hypothyroidism, there is no confusion. This is the another study published in NEJM of 5-year duration, where levothyroxine group of subclinical hypothyroidism, and they observed that IQ score in the children, not much change. P-value is not significant. And that is in the second trimester, 16 to 17 weeks of gestation. So levothyroxine has not significantly improved the cognitive function in the children if patient has subclinical hypothyroidism. So this is a very landmark study published in NEJM, and this is what we are going to face in future, that we have to do more efforts. We have to do more efforts to find out whether and or how to address this situation of lower IQ in children of mother with subclinical hypothyroidism. So no consistent evidence that subclinical hypothyroidism causes harm in pregnancy or that treatment with thyroxine is beneficial. All these evidence I have presented. Any treatment for subclinical hypothyroidism in pregnancy is currently based on low quality evidences. A low starting dose of thyroxine may be around 50 microgram, and thyroid function tests reviewed after 4 to 6 weeks to ensure no harm from iatrogenic thyrotoxicosis. So we have to see other way around also, that by giving thyroxine, we may not induce iatrogenic thyrotoxicosis in pregnancy, which may be again harmful for the mother as well as for the fetus. So more data are needed to inform the management of women with subclinical hypothyroidism who are positive for thyroid antibody. This is the latest statements published in the 2019. So what I want to conclude is that adverse effect of overt hypothyroidism in pregnancy is clearly established. However, there is a confusion about the subclinical hypothyroidism. Timing of L-toxin intervention during gestation likely to play an important role in the neurocognitive outcome in offspring, we have to start as early as possible. Duration and severity of maternal hypothyroidism are additional important factor in determining the neurocognitive outcome in the offspring. Thank you very much, and I hope I could understand. I could do justify to this topic and provided you all the evidences in favor of hypothyroidism and subclinical hypothyroidism and how to manage these patients in this scenario in our Indian population. Thank you very much.
Thank you, sir, for this very elaborative and very comprehensive talk. You have covered all the aspects beautifully, actually. Take-home messages. I think the most important is that if the TPO, if she is anti-TPO negative and the level of TSH of less than 4, then she does not need treatment. And however, if she is TPO positive and with a history of bad obstetric history and with even a level of 2.5 to 4, she needs treatment. TPO positive. So these are, I think, good take-home messages. So one question. You have shown in that Avon longitudinal study that subclinical hypothyroidism does not cause any effect on the neuronal development or the childhood performance or intelligence. But supposing she's got frank hypothyroidism, say with levels of TSH of say about 10, would it? I mean, what are the correlation with the subsequent performance, intelligence performance?
Sir, actually. In 1999 or around 2000, this James Haddo study has come, which was the landmark study, which have highlighted that hypothyroidism or low thyroxine levels in the mother in pregnancy around 10 weeks or so, 10 to 12 weeks of gestation, if that is there, and those goes unrecognized, thereby affecting the fetal levels and thereby affecting the IQ levels. And after that, study of Pop et al. Has also come. And then there are so many studies have come which have documented, but always there is a controversy on this issue because some got it, some have a negative result, some have the positive result. And I told you that those all because of the variation cutoff hypothyroidism or subclinical hypothyroidism taken into consideration. So this is all about subclinical hypothyroidism. For overt hypothyroidism, there is no controversy. Yes, overt hypothyroidism is a concern and it affects the maternal as well as the fetal as well as the children
can be born
at all points. So there is no confusion because in those the TSH levels are very high and thyroxine levels are very low. But the confusion and the controversy is about the subclinical hypothyroidism.
So, sir, in case if you have a patient with who is in very early pregnancy and with a TSH level of more than 10 or more than 15, would it be prudent to advise an MTP to them?
See, as such, when we see the guidelines or when we see the when we study the indication of MTP, this is not mentioned there. Although we know it causes miscarriages or it causes all these problems.
Retinism and
these all will be then the informed counseling and everything which will be taken into consideration.
Absolutely.
And,
yes.
And the second thing which we have to understand, these type of situations are very, very uncommon with us because mostly they abort spontaneously in first trimester only. But yes, we have to face sometimes these type of problems. Like the same thing will happen with the diabetes. If suppose in the first trimester they have very high
HbA1c,
what to do? So these are the all. So
I think counseling plays a very important role at this point of time. Yes, thank you, sir. I think we are a little short of time, so we would not take more questions.
Very nice presentation, Ashok.
Thank you, sir.
Yes, absolutely.
So I just thanks MOGS and ISOPAB, Mumbai Society, everything for giving me this opportunity and to have a wonderful discussion with lot of experts and legends from the Mumbai.
Thank you for joining, sir. It was a pleasure to have you with us. Thank you. And I would now like to hand it over back to the Master of Ceremonies for taking it forward to the next session, the eagerly awaited session on obstetric emergencies. Dr. Amity, could you take it forward?
Yeah, thank you, sir. Thank you for the amazing session. We now move on. I would like to invite the next chairpersons. Can I have the CV, please? Our very own dear Bipin Pandit, sir. He is one of the most sweetest and most approachable professor, our senior teacher. He is a practicing obstetrician and gynecologist at LA Shirandani Hospital, Powai. He is a gynecologist, Seven Hills Hospital, Marol. He is the vice president-elect at Foxy 2021, past president of the MOGS 2018 to 2019. He's the past joint secretary of Foxy 2015, treasurer AICOG 2013 Mumbai, chairperson for violence against doctors, Cell Foxy, past president of Association of Medical Consultants Mumbai. He's the former managing trustee of Association of Medical Consultants Mumbai. He has received a Lifetime Achievement Award from AMC 2019. He's a chairperson at MMC Cell AMC, trustee and past president, fellow gynecologist, past president Andheri Medical Association. He has special interest in laparoscopic surgery, high-risk pregnancy, and he has many publications and presentations to his credit. Also, he's a fantastic singer and a very, very, very patient listener and excellent orator. So please welcome on board Bipin Pandit, sir. Also, I would like to invite our very own. Can I have the slide, please? Yeah. I would like to invite our very own Sarita Madam, Sarita Bhalerao ma'am. She's an obstetrician and gynecologist to Beach Hospital, Reliance HN Hospital, Saifi Hospital, Bhatia Hospital, and Badia Maternity Hospital. She's the joint secretary of Foxy 2017. She's the immediate past president of AMWI Mumbai branch. She's the vice president of MOGS 2021. She is a member of the governing council of AICOG, and she's the chairperson of AICC RCOG West Zone. Again, very sweet, very approachable, and one of our mentors at MOGS. I really welcome you on board, madam. Please welcome. Good afternoon.
Thank you very much, Amity, for kind words. At the outset, we must thank the organizers, Dr. Raju Nagargatti and Komal Chavan, and President of MOGS and ISOPAP, Suchitra Pandit and Rishma. And without wasting much time, let me call upon all the panelists. It's going to be a very interesting panel on obstetric emergencies. Our first panelist is Dr. Rajendra Sarogi. Can I have his slide, please, so I can say a few words? Dr. Rajendra Sarogi, slide, please. He's a teacher of teachers and very experienced gynecologist, one of the senior most member, Professor Emeritus at GS Medical College, and head of the department at Dr. Aryan Cooper Hospital, senior consultant at Nanavati Hospital, and director of Sarogi Hospital, past president of Malad Medical Association. And he has written many chapters and books and papers and presented many publications. The next panelist is Dr. Arun Naik. Dr. Arun Naik is a professor and head of the department, LTMG and Sion Hospital. He was a president of Mumbai Obstetric Gynec Society, where at that time I was the honorary secretary. He has got various clinical fellowships, including one in Korea, and joined assistant editor at Foxy. And he is a winner of Foxy Korean Award. Our next is Dr. Vijayalakshmi. Dr. Vijayalakshmi, slide, please. Yes, she's a senior consultant of OBGY at Sundaram Medical Foundation, Chennai, president-elect of OGSSI, chairperson of Research Committee of IMS, member of Quiz Committee Foxy, and member of Quiz Committee IMA. Welcome, Dr. Vijayalakshmi. And Rinamani, can I have Rinamani's slide? Rinamani is a good friend, member of MOGS committee, professor and unit head of HBT Medical College and Aryan Cooper Hospital, chairperson of Foxy Perinatology Committee in 2015-17, president of Mumbai Breastfeeding Promotion Committee 2019-20, core committee member of the Foxy Violence Against Women Cell in 2015-21. May I request Sarita Bhalerao to introduce the remaining panelists, please?
Yes, thank you, sir. I'd like to introduce our next panelist, and that is Dr. Rajashri Katke. Is her CV there? Yeah, I'm very happy to see Dr. Rajeshri Katke, a very dynamic lady, and she's done a lot of work on oncology. She's now the professor and the head of department at the Grant Medical College, Mumbai. She has a lot of publications. She's received many awards, and she had a very successful tenure as the ex-superintendent of Kama and Alblis Hospital. Welcome, Dr. Rajeshri Katke. I'd like to introduce Dr. Komal Chavan. Dr. Komal Chavan, she's a very, very enthusiastic and hardworking person. She's the chairperson of the FOXY Medical Disorders in Pregnancy Committee. She's a joint secretary of ISOPAB Mumbai chapter, and she has received many prizes, including the Dr. Durusha Best Committee Prize, the R.D. Pandit Prize in the senior category. And she is a member of our managing committee at MOGS. Our next panelist is Dr. Abhijit Kher. Is Dr. Abhijit Kher here? I saw him. Yes, he's here. Wonderful. I can see him. And he's a senior practicing gynecologist. He's been in private practice for more than 25 years. He's been an honorary gynecologist to municipal hospitals. And currently he heads the OBGY department at the Shatabdi Hospital, Kandivli. He's a PG guide from DNB and DGO. So we have a wonderful panel with us. And can I now share my screen? Yeah.
Rita, you can start with the first case, please.
Yeah, we have a wonderful panel with us, and we have people who are from, private practice, people from municipal hospitals, and so we are going to get a very good option. Okay, now 1 second. This slide is not moving. I'll just try.
What about Dr. Aspi?
Yeah, no, Dr. Aspi. Yeah.
He had to go to his native town urgently for some work, so he has opted out.
He could have joined us from there.
He said, no, I might be driving, so I may not get connectivity.
Okay, so let's go straight into our panel. We've got 5 interesting cases. And obstetric emergencies has always been our nightmare. How often have you dressed up for a wedding and then had to suddenly rush off? Or how often have you been woken up in the night? Or you thought that you'll finish in an hour and come home and you are stuck? And sometimes things can turn even worse, where you have, a lot of anxiety, and we are dealing with 2 lives and medico-legal problems as well. So thank you, Dr. Nagarkati, for giving us this wonderful opportunity and taking this wonderful topic. So our first case is a 30-year-old female married since 10 years, a spontaneous conception, and she comes with 9 months amenorrhea to the emergency room with an episode of bleeding PV, no leaking, nothing else is there. Her first trimester was fine, second trimester was fine, but she has a severe pain in abdomen and she comes with bleeding PV. So I'm going to start the first question, and I'm going to ask, we'll start with Dr. Abhijit Kher. Dr. Abhijit, how do you approach this patient? Is Dr. Abhijit there? Can you unmute yourself?
Yeah, I'm unmuted.
Yeah, we can hear you.
Yeah. So in this case, since it's a 3rd trimester bleeding, the differential diagnosis would be mainly between abruptio placentae and placenta previa.
Yeah.
So we should go ahead with the clinical findings. In a typical case of abruptio placentae, we will see the patient showing some amount of hypotension and tachycardia. There may be pallor. And on per abdominal examination, we may find that the uterus is tonically contracted, tense. The FHR may be either, there may be bradycardia, or sometimes even there may be IUFD, so FHS may be absent. And on the per vaginal examination, we'll find obvious bleeding per vaginum.
Okay, I'm going to stop you at this stage, and I'm going to ask Dr. Komal Chavan. Now, suppose patient is an unregistered patient, comes in emergency, and you don't have any previous record. She's not had a previous sonography, or she says, I've come here on a holiday, all my reports are back somewhere else. Then what do? We don't know where the placenta location. Dr. Komal, are you there? Yeah.
Yes. See, what happens many a times, we have such patients coming in a BMC setup who have not been registered or have lost the papers, have come from outside. And then when the patient is come, so clinically, first examination, as Dr. Abhijit Kher said, we need to do an examination. in this on a per abdomen examination, if we find a uterus which is very tonically contracted and not getting relaxed, with a complaint of bleeding, she has had bleeding earlier, and we do a gentle per speculum examination just to see how much is the bleeding, if it is really profuse. So it can be either a concealed or a revealed kind of a bleeding, and if it is definitely coming out, means it is a revealed bleeding. And we need to ideally get a quick ultrasound here to know how much is the retroplacental hematoma, and also to we can use our Doppler and know about the fetal heart sound, because we are more worried about the viability of the fetus, what is the compromised status of the fetus, and we know that if she is into labor, if the effacement is good, what is the dilatation, that is real important parameters which will be taken into account when we have to plan the further course of action. So if she is going into a favorable cervix, yes.
So let's go ahead now, and I'm going to ask Dr. Katke. Dr. Katke, if your resident is phoning you in the night with this sort of problem, what are the emergency investigations that you will advise?
First, I'll just ask what is the general conditions, and the main important thing, as Komal said, it could be abruptio placentae. So basically, a coagulation profile is very important, BT, CT, prothrombin time, and we have the facilities of going into the DIC fibrinogen level, how much it is, D-dimer. If you have that facility, then we can go ahead of that, because it gives the exactly idea in which condition of the coagulopathy she is there, because we are not aware how much is the retroplacental clot is there. So it depends upon that, and we expedite our mode of delivery also, depending.
Okay, let's stop you here. I'm just coming to the investigations first. And Reena, I'm going to ask you, how long will the clotting profile take in our setup, and how will we decide how severe is the abruption?
So Sarita, I would like to just start from one important point. She's a multiparas patient, 38 weeks. And I would, in fact, sometimes I have found even being in a teaching hospital, getting that ultrasound done may delay the treatment. So I would say that going with what my esteemed panelists have also said, I would be more prone to do a gentle per-vaginal examination. This probably had a previous ultrasound at some point which had shown that the placenta was not low-lying. So I will not delay the management. I would start the treatment side by side. And this is a patient where you may lose the baby in that delay of 1 hour going for ultrasound and coming back. So I will do a PV, side by side, do the investigation for clotting test, bedside clotting test, clotting time, bleeding time is still something valid, because in emergency hours after 4 o'clock, even in a lot of public hospitals, you do not get the complete coagulation profile, and patients are having to send it with public-private partnership. So the management and the investigations in a suspected abruption should go side by side. In a multiparas patient, ARM and oxytocin might save the baby in time, and you will deliver a live birth. Definitely.
Okay, let's go ahead now, and I'm going to ask Dr. Seshadri. Madam, in your opinion, how will you deliver this? How should this patient be delivered?
Sarita, if you permit me, since if you say history-wise, of course, we are focusing towards abruption. But at the same time, if the previous cesarean history is there, then we should also suspect pains along with threatening scar rupture and anything with severe pain. We should not take that out of our mind. That's very important, because that also can present like this. The other thing is, and of course, the placental, normally we say placental bleed comes as low placental bleed comes as a painless bleed. But sometimes if it is also because it's a term pregnancy, contractions have come and placenta is also low, that's also possible. One more thing I would like to say, as clinical sense is very important, but ultrasound, even whether it takes time or not, in a suspected abruption, I think ultrasound has a very low sensitivity. It just shows a big placenta. As far as abruption is concerned, usually MRI is diagnostic, but we have no time to do all those things in emergency. So clinical sense should prevail. I think ultrasound only shows a bigger placenta. It does not even correlate well with immediate abruption, where it can show some retroplacental clots. And we know a concealed or a revealed hemorrhage both can happen here. And sometimes we do get abruptions, fetal heart goes off, but then there is no bleeding also.
Okay, let's go ahead now. I'm going to ask Dr. Sarogi, sir. Sir, how best should we deliver this patient?
First and foremost, let me tell you, abruptio placenta is an emergency. Now she is gravida 3 with previous 2 full-term normal deliveries at term. uterus is tonically contracted. So there is no need to go ahead with sonography, which may take some time. There is no need to go ahead with the DIC profile, which will take another 4 hours for you. Your treatment should start immediately, and the best treatment in a case of abruptio placenta is do a PV and do ARM.
Right.
Artificial rupture of membrane is the best line of treatment in a case of abruptio placenta. Now here, the very fact she presented with bleeding PV, that means it's probably a revealed type of abruptio placenta, or at times it can be a mixed type, but more likely to be revealed type. So you should not be that much worried. The very fact her pulse and BP are normal, that means the blood loss is not to that extent. So go ahead with ARM, start an oxytocin drip, and try to deliver her as fast as possible, monitoring the heartbeat of the baby. In case she would have been a primey with probably closed os and you can't do ARM, of course, clinically, if you feel that FHS may be dropping down, go ahead with cesarean section immediately rather than waiting for anything else.
Okay, so let's go to Dr. Arun Nayak now. And Dr. Nayak, what are the problems at cesarean section and what are the complications one should anticipate?
Sarita, can I interrupt here?
Yes, of course.
Sarita. Yeah, Dr. Sarogi, I want to ask you one thing. Now, this case is okay, but suppose it's a concealed accidental hemorrhage. How will you diagnose it and manage it? Totally concealed, there is no bleeding.
Concealed accidental hemorrhage, the problem is the amount of blood loss and the condition of the patient. There is so much
discrepancy, yes.
There is so much discrepancy. There will be severe tachycardia, there will be anemia, there will be decreased BP, and that means definitely it gives you an idea. Still, you have to go ahead with ARM. If possible, try to do ARM. Start an oxytocin drip. If she's a multipara, she'll deliver fast. If the uterus is not responding, you may be forced to go ahead with cesarean section. Otherwise, you'll end up with all possible complications. Now, the studies have shown the complications are 4 to 6 times increased risk of preterm pregnancy with abruptio, 2 to 4 times increased risk of IUGR with abruptio. Stillbirth rate is 22 times more with abruptio, and neonatal death is 13 times more with abruptio. So with concealed cuvalier uterus type, you'll be forced to go ahead with cesarean section even if it's a dead child, just to save the mother, otherwise she'll end up with DIC and all sorts of complications.
Okay, Dr. Arun Nayak, coming to you now. What precautions will you take when you're taking this patient for cesarean section?
Yeah. Now, before going to the cesarean section, 1 or 2 points I want to make clear. Like Dr. Sarogi said, that your management and assessment should start simultaneously. We cannot wait for the reports. Second thing is, I am a strong proponent of ultrasonography machine in delivery room itself.
Correct.
We should not be in the labor room itself. Okay, we shouldn't be landing in a situation where we have to send this patient to sonography to radiology department and wait for the report. It should be available for each and every treating obstetrician in labor ward itself. Okay,
and we should be able to do it.
Yes, all gynecologists, we are competent enough to do sonography, and we are certified sonologists. We don't have to worry about whether we can, whether we require. All of us are allowed to do sonography for our obstetric patients. So that should be very clear to all our colleagues. Okay, having said that, coming to the management and doing cesarean section, yes, like Dr. Sarogi and Dr. Rinavani mentioned, we can just do the bleeding time, clotting time, bedside test, and if they are within normal range, we need not wait for PT-INR and we can go ahead. Now, 1 or 2 things, like if patient is primary, now this patient is multi, so she is likely to deliver vaginally. If we do the ARM, she can progress very fast. But one point one has to remember, what is the condition of the fetal heart rate. I have seen when there is a massive abruption, a fetal heart sounds of 100 or 110 will suddenly drop to 40, 50, and we may lose the baby. So if patient is not progressing very well, then this is one factor one has to remember. What is the type of fetal heart sound, whether they are regular or whether there is a bradycardia. If they are irregular, if patient is not progressing very well, no harm in taking this patient for cesarean section. Very often, if there is a concealed APH, we will find the uterus to be cuvalier type of uterus. Now, most of the time, by using oxytocin, we can becomes contracted, and we need not worry about atonicity in coelar uterus. But in case we find the uterus to be very flabby, it is atonic, one may have to start using protocol for managing atonic PPH patient's uterus, which is atonic, and then decide whether patient requires selective devascularization, whether we should do the internal ligation, and in rare cases, one may have to go ahead with even obstetric hysterectomy. Now, the point in cesarean section that we have to remember is as soon as we deliver the placenta, the large retroplacental clot is going to come out. So we'll have to assess how much is the blood loss, because this patient is likely to go in sudden hypotension as soon as this large volume of blood is removed from the uterus, and we'll have to adequately compensate that with the blood transfusion if she has lost a significant amount of blood.
You are muted, Sarita.
Sarita, you're muted.
Yeah, I got it. So I think that's wonderful. Just two last questions, and I'm asking Dr. Seshadri, what a patient has had this trauma in this pregnancy, what is the recurrence risk in the next pregnancy? Should we be worried about it?
Generally, the incidence itself is only 1%, but recurrence, they say it could be even 6%, though there is no definite cause. And they say you cannot really predict and prevent with certainty when abruption can come on. But
anything
then,
you can do, anything you can supplement, Dr. Sarogi?
Yeah,
if there is a hypertensive state which is specifically related to this, then probably we should control the hypertension early. And normally they say, I don't know how much it is, alpha fetoproteins and first trimester papa increase and reduction of alpha fetoprotein, they are all predictors, but we don't know.
What about folic acid?
Folic acid is supposed to have a protein.
That anyway we are now almost giving to everyone, periconception itself.
And what if the mother is an Rh negative? Dr. Sarogi? Anything?
You have to give anti-D to the mother.
Yes. And maybe her requirement may be more. Reena, anything you want to say about anti-D?
So ideally, we should have the
Clive bed test
done and judge the amount of hemorrhage. But basically, it's a clinical judgment that we have to use sometimes, particularly if you feel, and if the hemorrhage has been large enough to kill the baby, it is definitely significant, even if we don't manage to do that classification. And we need to look into it. Or if there's been covalent uterus, you may need to give a higher dose of anti-D.
Okay. I think we'll move ahead now. Dr. Bipin Pandit, over to you.
Yeah, thank you, Suchitra. Now we have tackled one case of APH, the another one with a painless bleeding. 34 years old G3P2 homemaker registered and booked case at 29 weeks of amenorrhea comes with a painless bleeding. So obviously the diagnosis is very, very clear. So sonography is done and it is showing complete placenta previa. Now in her history, she gives that she has not visited ANC visit in the first trimester. Second trimester patient had one first ANC visit at 16 weeks when she had first episode of little bleeding. Scan also showed complete placenta previa. Now, how will you manage this, Dr. Abhijit?
Yeah, basically, since the complete placenta previa has been diagnosed, this patient should be advised as much complete rest as possible. She should be covered with tocolytics. She should be given proper hematinic so that her hemoglobin is well maintained. And we should tell her to properly follow up in the antenatal OPDs.
Yeah, let's talk about first 16 weeks. How will you manage and at 28 weeks?
Okay.
Completely covering the internal os at 16 weeks. What is the chance of this placenta getting migrated? We have seen marginal placentas, they do migrate.
Yeah, they do migrate. But complete placenta previa migrating, becoming non-previa, the chances are relatively less. But even then, we would follow the patient with repeated sonographies till term.
I think complete placenta previa is unlikely to migrate because complete placenta previa by definition is something which is covering the os coming from one side, covering the os and going to the other side. So we'll have to warn this patient that she has a complete placenta previa. She will have to be extremely careful. She should avoid rigorous activities. She should avoid sexual activity during throughout the pregnancy, because that itself is likely to cause a severe episode of bleeding. At 16 weeks, if she has come with a bleeding episode, this is something called heralding bleeding. That is, we are warning bleeding of placenta previa, and this is an opportunity for us to explain to the patient what precautions she has to take. This bleeding is most often it's a minimal bleeding, self-limiting bleeding, and like you mentioned that with tranexamic acid it has come under control. But this bleeding is likely to again recur later on in the pregnancy. So all the precautionary measures this patient will have to follow, like excessive rest, avoiding heavy work, and later on in the pregnancy, if she has come with again second episode of bleeding, that is likely to be more severe, and depending upon what is the period of gestation and amount of the bleeding, we'll have to decide the further course of management. If the second bleeding episode is again minimal bleeding, maybe we'll require admission. We'll have to give complete bed rest, maybe to a little bit of Trendelenburg position, so that the pressure of the presenting part on the placenta will be avoided. And if bleeding stops, then we can give conservative management to continue this pregnancy till we reach a good gestational age of 34 or 35 weeks.
Good. Dr. Reena?
So absolutely what
want to add
I go with that. And this King's phenomenon of placental migration does not apply to complete previa. But what we have described in books, the McAfee's conservative regime, is to try to pull the patient through. But if that doesn't work, there's a role of giving prophylactic steroids for lung maturity when the patient has reached 28 to 30 weeks. Because when that's, as Arun mentioned, that the bleeding which occurs in the third trimester after the first warning could be torrential. So we give prophylactic steroids, make sure her hemoglobin is above 11. Here again, in our national anemia prevention program, there is a role of considering parenteral iron in women who are at high risk, which could include these, to make sure that they are in a good condition in case any intervention is required.
Yes, Dr. Rajeshri, at 28 weeks, you will definitely like to conserve her, give her steroids, and see how much she can progress up to 32, 34 weeks. At what time, around 28, 29, 30 weeks, you will take the decision to terminate?
If we such patients, we have to be hospitalized under the care. And I would like to see one thing is that she has a complete placenta previa, so we should know the complete extent also. And if there is any penetration, adherency of the placenta is very important. Though she may not have a scarred uterus, but we are still seeing such cases. And in that after, we have to keep such patient under observation and pull on, even 30 to 34 weeks till the maturity comes on a McAfee regime. But if suppose she has a bout of bleeding, then you have to prepare yourself for the cesarean section, lower segment cesarean section or classical, whatever it is required after opening the case. And the second important thing is that here, apart from these FCM injections, keeping of the blood and blood components ready is very, very important, because we don't know when they will bleed torrentially. Even in the night, we'll get a call, she started bleeding, and then everything goes in a hurry and we don't get a time to manage such patients. So you have to keep everything, keep fingers crossed, and pull the patient on a McAfee regime. By keeping for every moment, she may land up in a cesarean section.
Yeah, thank you. Dr. Sarogi, today the incidence of placenta accreta has increased, and we all know what is the reason for it. Suppose this is a case of previous LSCS, little diverse. What would you look for in a placenta previa with a history of previous LSCS? What precautions we need to take and what care we need to take?
First and foremost, if it's a case of placenta previa, you have to find out whether it is anterior placenta or is it posterior placenta previa.
Yes.
Because if it is anterior placenta previa, there are good chances that with previous LSCS, 5.3% of the cases you will find morbidly adherent placenta. So you have to be prepared with the idea that am I dealing with a case of morbidly adherent placenta? And if it is so, then you have to be fully prepared. You have to counsel the patient if she has come early. Now, for example, if she has come at 10 to 12 weeks with probably pregnancy occurring at the lower segment cesarean scar, so-called cervical pregnancy, so-called isthmocele pregnancy, you counsel the patient about it and try to terminate the pregnancy, because there is no point in continuing with such a pregnancy. If she has come late, and you found that it's a morbidly adherent placenta, then you try to pull on the pregnancy till about 32 weeks and then go ahead with elective cesarean section with consent for hysterectomy.
Now, one question. I know that you have managed maximum cases of Akrita in Cooper Hospital. I was there. Most of these morbidly adherent placentas with previous 1 LACs or 2 LACs, they not necessarily bleed. So would you like to wait till the baby becomes little more mature and not hurry up at 32 weeks? Just question. Practical question.
I'll put it this way to you.
Yeah.
If it is Akrita, you are sure about Akrita, you can wait. But if it is becoming Inkrita and Perkrita, it's going to be little risky for you. In that case, it's going to be dangerous.
And how will you ensure it? By doing MRI?
Even good sonography can reveal everything. Your sonography, transabdominal, transvaginal can reveal, or transperineal can reveal. Your sonography with color Doppler can reveal. Your MRI can reveal. So MRI is not a must to diagnose all cases. However, MRI is useful for posterior placenta previa, Akrita, Perkrita, or sideways, lateral placenta, Akrita, Inkrita, Perkrita. MRI is useful to find out any congenital malformation which may be associated with this. So in that case, MRI is very useful. Otherwise, go ahead with simple sonography with color Doppler, and that should be able to suffice.
Dr. Arun Naik.
Yeah.
Dr. Arun Naik.
Like Dr. Sorogi mentioned, anterior placenta previa in a case of previous cesarean section, there is definitely more chances of it becoming adherent. But posterior placenta is no safe. There are cases which are reported that even in cases of placenta previa, which are previous cesarean section, and the posterior placenta also have the cases have been reported where the placenta is adherent. Maybe the trauma which is caused while delivering the baby during cesarean section, that trauma itself has caused the adherent placenta even when it is posterior. Second thing, coming to whether we should keep these cases for elective cesarean section or whether we should allow them to grow a little more. See, Bipin, there's always a risk that this patient may have bleeding at some odd hour, maybe middle of night. Now that takes away a lot of options in management when patient comes with bleeding in middle of night. If we keep this at 32 or 34 weeks, we can plan this patient for embolization. We can plan the management. We can keep our urologist colleagues, because most of the time, if it is a Perkrita, the bladder is likely to be involved, and inadvertently the bladder is likely to get opened. Though we are in a position to suture the bladder injury, or we can suture the bladder, we don't know how far it is Perkrita, how much it is penetrating into bladder. I have managed a case where the majority, almost 75% of the bladder, we have to excise, and that is the time where we may require help of our urology colleague. So we can plan properly. We can do it during the daytime when we have the help available, and in the middle of night, all this management may not be possible.
Yes, point well taken. Dr. Rajeshri and then Dr. Rina. You want to add something?
Yes, because nowadays with a scarred uterus, we are seeing most of the morbidly adherent placentas. And in last week only, we operated like a placenta Perkrita. When we opened the rectus sheath, the whole placenta was adherent to the uterine muscles, placenta, and the peritoneum. There was no uterine, upper uterine segment muscles. It has been all eaten by the placenta. So it becomes very difficult because these patients are admitted. We have already done a MRI because it was a huge placentosis in that. Only the flap of the lower segment and the os has been remained. So we delivered through the placenta in that, and there was no chance of even doing the vascularization, selective vascularization. And we have sent this for the interventional radiography. They said, madam, we cannot embolize this placenta. You have to take a grade 5 consent, open her, deliver her, and then we will see something. After that, we immediately do a OH for her, and we delivered a healthy baby, 2.7 kg male, and we ligated bilateral internal iliac. This is how we could able to come. I fully agree with Dr. Arun Naik, sir. Many of the times, these are the either adherent or the placentation goes into the vesical plane and the bladder. In that cases, then it becomes very difficult, and there is a role of this is in embolization to selective embolize those vessels which is going to the bladder, and then you can deliver it, and you can save the bladder also and the patient also. So there is
Dr. Arina?
There are 2 or 3 important points I would just like to add in this wonderful discussion which has happened. One thing is, it's not just previous LHCS, previous MTP, curettage, missed abortion, risk of operation, and we do get placentae which are not necessarily anterior. So all the points mentioned before are absolutely valid. And MRI has a limited role, especially if you're not sure on the ultrasound. And when you're talking about embolization, it has been suggested you put in the balloons, but do not inflate them until you're ready to deliver the baby, because that again can lead to problems in the fetus. And what is more practically available for us as obstetricians is that ligate the uterine artery before you incise the uterus. You will have less bleeding when you're trying to deliver through the placental bed, particularly if it's an anterior placenta.
Dr. Abhijit, one thing I want to ask you. Arun.
Can I say here, Rina, even after embolization, even after uterine artery ligation, and even after internal iliac ligation, the amount of bleeding which occurs when placenta is percreta or increta, it's unbelievable. Within 5 minutes, patient loses something like 2 liter, 2.5 liter to 3 liter.
True.
So it's not that by doing prophylactic uterine artery ligation, we are going to have less bleeding. No, it's not so.
Yes, I agree with Dr. Arun.
We have to keep blood and blood products issued and ready in the OT, even if it's an elective section. That is one point which...
we will talk about it, active management. Dr. Saru, you want to add something?
Basically...
You said, one question I want to ask you. You said MRI is not a must. I have 2 issues about it. Many a times, you get a sonography report where the placenta is not adherent and it turns out to be adherent. And vice versa. They say placenta is adherent and it turns out to be, it comes out in your hand very easily.
Correct.
So when the facility is available in a city of Mumbai or big cities like Kolkata, and medico-legally, is it not important to ask for MRI whenever you suspect?
No.
I'm asking you because...
I'll give you examples of MRI also.
Yes.
MRI done for a huge abdominal tumor, suspected ovarian cyst. Report came as ovarian cyst on MRI. But when we opened up, it turned out to be a huge leiomyosarcoma of the uterus. Now you tell me.
No. What I'm trying to tell you is there are certain MRI specialists who are specialized in adherent placentas. We need to identify them because they have very good experience. Yes, Rajashree, Dr. Rajashree.
Can I tell, because we are getting more of operating this increta percreta. See, the role of the MRI, it gives the idea about the extent of the tissue place, that is one thing, and the invasion of the placenta, that is the second thing. So you can plan all of your operative things. And even in a medical legal, I was on one case where the patient or doctor's wife has been admitted for this placenta came adherent, and there was no amount of the blood kept ready for that, and the patient died in a CCU. And after that, all these questions they have asked whether the MRI was done or not.
Yes.
Medically,
because we have got a case medically where they asked why MRI was not done.
Totally agree, Bipin. I think it's better to make mistakes by committing ourselves rather than
only 2
committing
points of the
ourselves.
blood was kept. They have asked so many.
See, what I'm trying to, Rajashree, what I'm trying to tell you is a practical aspect, because in Maharashtra Medical Council, where I was executive council member, we got a case where the question was asked why MRI was not done.
Yes,
I agree with Dr. Saluji that it is not a must, but sometimes we try to save patients money and trouble, and we'll end up in trouble. Dr. Abhijit, you want to add something? Yeah.
So can I add?
Yeah.
I was saying we are talking so much about the placenta accreta syndrome, PAS, whatever. That is there. But even otherwise, the abnormally located placenta, the chances of PPH are even otherwise quite high. So not leave alone the placenta accreta syndrome, whether it is diagnosed earlier, not diagnosed, or diagnosed on the table. But even the chances of PPH are going to be high, because this lower segment is not going to contract very effectively, and we should be really quite alarmed and ready to even do those internal sutures that we do at the placental site. I think it's very important to keep that in mind as well, not all the time thinking about the placenta accreta only. And also, of course, the arrangement with the blood and the labs and all those, even massive transfusion protocols and all those things have to be kept in mind. And I think before even, if we have time and if we are going to shift for elective surgeries for this, we always make it a point that we also inform the ICU wherever the facilities are there, because it's very important. Sometimes you get stuck in theatre and it's very important to shift from there. So preparation goes.
Yeah.
Bipin, I think I will prefer to do MRI in this patient when sonologist says the report that there is a possibility of adherent placenta, because you were asking from the medico-legal aspect. If from medico-legal aspect, somebody may question me when facility is available, why it was not done. That is one.
Exactly.
And second thing is, I think it's always viewed that act of commission is better than act of omission. So if I don't do MRI, then I think it will be treated as a more severe negligence rather than when I'm doing MRI.
Today the time has changed. We need to change with the time. Dr. Komal, in short, can you just summarize the management?
Yes. I'll summarize.
Placenta accreta adherent, because the incidence of previous cellulitis is increasing. The incidence of accreta is also increasing.
Yes. Sir, I just wanted to make a point regarding this MRI thing. You see, even everybody is in favor of MRI, but as whatever I have seen many colleagues, like many doctors all over India, they're not doing MRI. They're saying that ultrasound, a good ultrasound detecting is considered standard. But what I would take a single report, if they're doing an ultrasound, at least they should reconfirm, and based on that ultrasound report, if they keep all the arrangement ready and anticipating all the emergency, I think they would be sorted. If they are prepared, they are knowing that they are managing a case of an accreta based on an ultrasound, and if they are prepared for it, then I think it is not an error on their part. But if they are not taking it very seriously and not keeping all the things ready, they may land up into difficulty. So MRI for me, I am doing it.
No. Let
there
me
are
make
many
it very
people
clear.
who are not doing, sir. That is the issue. Problem is there. Sir.
Komal, it's not a question of whether to do MRI or no. A good ultrasonography will definitely tell you. Now, the point here is very important, is the outcome of this case, however well you manage in an institution, is not in your control. Suppose something goes wrong, then the questions come, why these things are not done. Am I right?
Yes.
Dr. Abhijit?
Yes. And even the
So I think in every case, if you are doubting an accreta, we should do an MRI, because even if an ultrasound, if you are strongly suspecting an accreta on some patient, if she's a previous 3 LSES, then even if the ultrasound is not showing accreta, I think we should go ahead and do an MRI in this patient.
Exactly.
So that at least we know that she's a high risk for an accreta because she has a previous multiple surgeries. So I think such patients.
See, we need to wind up this case. So anybody wants to add anything, Dr. Abhijit?
No.
Most important thing I want to press a point here is these cases must be managed in an institution.
Only,
not in your small nursing homes.
Definitely.
Yes, Abhijit, you want to add something?
No, I think Sarogit sir, Arun and Rajashri madam has discussed it very well.
Yeah.
Thank you. Sarita, please start with the case 3.
We'll go ahead, and this is a 20-year-old
See, one
female.
request, we need to finish 5 cases.
So we'll go a little quickly now.
So we have to be brief and not to repeat.
So this is a 20-year-old patient, married since 1 year, primary gravida, came with 1.5 months amenorrhea with pain in abdomen and bleeding PV. On examination, her pulse was 120 per minute. BP had fallen to 80/60. She was bleeding. There was bulky uterus, fornical tenderness, and cervical motion tenderness. Let's start with Dr. Komal. Komal, how would you proceed? We'll go very quickly now.
Yeah, so now this patient is actually giving history of pain and some amount of bleeding, and amenorrhea history is there. So we would, the findings, examination findings are pointing towards an ectopic. So the possibility of she having an ectopic pregnancy is very high. So we need to now.
So what is the first thing?
The first thing is to know whether now it is a ruptured or an unruptured, and seeing.
So first we'd like to do a urine pregnancy test right immediately, right? We'll do a
urine pregnancy test would be the first thing.
And that UPT comes positive. Next what?
Next, we now know that definitely a UPT is positive and she is having a ruptured pregnancy. That is a diagnosis what we can make. And then we need to know whether it is because of her clinical finding that there is a guarding and tenderness and BP is falling. So possibility of rupture would be high. So ultrasound, if it is there on the bedside and quickly available, I think can be done. Also a culdocentesis, you can do a culdocentesis and find out whether there is an blood which is showing an ectopic pregnancy. So that can be done on an as a bedside for the patient. Or else
so I'm going to stop you at this stage and ask Dr. Reena, because Reena said, 3-4 hours go in asking for that sonography.
No,
Reena, is that true?
Bedside. If it's bedside,
no. So let's ask Reena. Reena, my question to you is, if you know it's going to take 3-4 hours to get that ultrasound done, how do you proceed in that situation?
Sarita, here, when it's a clinical, firstly, I would like to say culdocentesis is now reserved for very limited conditions. In this day and age, I think very few of us are doing an abdominal tap or a culdocentesis unless there is no other option. With a clinical picture fitting into ectopic, if the patient is hemodynamically unstable, then yes, it justifies if you have any a possibility, do a culdocentesis and think of an exploration. But in most situations, if you can get the ultrasound done, this is one of the situations where somebody like you should accompany the patient or a senior resident accompanies, and that 3-4 hours can get cut short to 20-30 minutes. But side by side resuscitation of the patient, sending the blood for cross-matching, and ideally I would, here it's a ruptured ectopic, but if I'm suspecting ectopic, a beta HCG in this day and age is possible almost everywhere. So I would not rely.
But it takes time, no? It takes time. It takes time.
Especially if the patient is otherwise hemodynamically stable, I would like to send a beta HCG side by side. And
I'm going to
cross-match.
Yeah, so I think that's very clear. Resuscitation, culdocentesis, which we rarely do now. And then we come to cross-match, yes. And Arun, I'm going to ask you now, what surgery?
Okay. Now, Sarita, before I go to the surgery, don't throw away culdocentesis out of the window. Okay. Now, see, if you are getting this clinical picture, sonography is not possible, say for whatever may be the reason, for 3-4 hours you are not going to get sonography report, then there is a place for culdocentesis, there is a place for abdominal tapping. Because whatever sure you may be that this is a ruptured ectopic pregnancy, if you do culdocentesis and you find a blood there, then you can convince the patient that immediate surgery is necessary. Otherwise, patients are not likely to agree for your immediate surgery. Now coming to the surgery, I think today's era, laparoscopic surgery has become, it is accepted as a gold standard for managing ectopic pregnancy. Even when there is a massive hemoperitoneum, we can think of laparoscopic management for ectopic pregnancy. Unless like laparoscopic facility is not possible, then we can think of arranging blood, keeping adequate blood, and then going ahead with a laparotomy.
So I'm going to stop you here and ask Dr. Sarogi, because I had this problem during the lockdown. There's a practical problem that the hospital said no COVID test. Now, how do you handle this?
In this case, probably you treat it as a COVID positive patient and go ahead with management. How we used to do with HIV positive patients without knowing the HIV report. We took all possible precautions and went ahead with the surgery.
And in that scenario, would you advise laparoscopy or laparotomy?
Definitely laparotomy rather than laparoscopy.
No, laparoscopy. So what are the advantages? I'm going to ask Dr. Seshadri, what are the advantages of doing laparotomy in this emergency situation?
See, I'm actually always pro laparotomy whenever we suspect rupture. I don't venture with laparoscopy, but I know the pure laparoscopists, they will say we can definitely do, because it needs to be, depends on your skill. You don't have to really worry that you have to do laparoscopy. If you're comfortable with laparotomy, I think you must do that, because saving the mother is more important. Quick getting in, quick getting out is important. Anesthesia wise, I think they will give some kind of an extra oxygen and then do it off. They are quite comfortable giving epidural if they want, or GA depending on the anesthetist choice. I don't interfere with that. And of course, practical problem of COVID now, we all presume that it could be COVID positive, as sir has said, and we move ahead and we do.
What incision? What about the incision?
Incision, we give low transverse scar only, like
so fan and steel incision, no vertical?
No fan and steel incision. Yes, definitely.
It's quicker, no vertical incision?
No, we are now quite used to. Yes, years before we used to give only midline vertical for even cesareans, but now I think over the years we are as quick in transfers as well. So we can definitely do that, low transverse incision or phalansteal or whichever, keeping the extent small because we have suspected. We have an ultrasound in our department as well, so that quickly we can run through and we can have a diagnosis. Of course, as everybody said, cultocentus is far in left behind, and we don't do that. Previously, we used to do EUA and cultosynthesis. Now, no. And salping, am I supposed to say about salping?
No, I think we'll go to Dr. Abhijit Kher. Dr. Abhijit, in your opinion, salpingectomy or salpingostomy? She's married since 1 year. She's 20.
Sarita, till Abhijit comes in, I just want to say that CB-NAT is equally good as RT-PCR in most situations. And an indication within 2 hours is the turnaround time. Even in our public hospital,
antigen
if
test
you are
is
suspecting this and you are considering it a laparoscopy, you can get a CB-NAT done.
Can I talk?
Advantages of doing laparoscopy it can be done under regional anesthesia, combined spinal epidural and not GA if the patient can tolerate the regional. This again is a choice based on the anesthetist because GA is an aerosol generating procedure.
Right.
You're not sure about
it. My anesthetist during the lockdown, they preferred to give spinal, and that is why in a COVID uncertain patient, they were not happy to give GA.
But Sarita, I think from those days when initial stages of COVID infection, things were not clear. Now, after 1 year, almost a year of COVID infection, things are becoming more clear.
Sarita,
things are becoming.
There are ICMR guidelines now they have, and every institute, even a Directorate of Medical Education has given the guidelines how to operate a non-COVID cases in a COVID pandemic. So in that, RT-PCR is the must, because that is the one. And what Sarogi said, sir said rightly, laparotomy will be the choice of the thing when you don't know the COVID status, and laparoscopy, general anesthesia if it is needed, then AGP is the biggest problem in that. And that is not in their guidelines also. So anesthetists will again refuse that because everyone is doing the guidelines.
So I think, I think you're right. And I think that in an emergency situation, we should not worry about doing laparotomy. Let's modify what we used to think that, and of course, laparoscopy offers many benefits. I'm not saying no, but in this particular situation, it may be laparotomy may be a better example. Coming to Dr. Abhijit Kher, the last question on this is salpingectomy or salpingostomy. What would you say? Dr. Abhijit, are you with us? Okay, Komal, coming to you. Komal, would you like to take that?
I think that if in this situation, what you have presented, this patient has got cultosynthesis that is positive. That means this is a ruptured ectopic most likely. When there is a ruptured ectopic, there is no question of doing salpingostomy. The tube probably is already damaged and we'll have to think of doing, if it is maybe mid-segment, maybe I will think of doing just partial salpingectomy, just taking out the segment of the ruptured tube, and maybe in future, if possible, we can do the re-anastomosis and then give a patent tube for this woman. But otherwise, doing a partial salpingectomy is the method of choice.
So I think very clear messages. Let's move to the next case without much ado. Over to you, sir.
Thank you, Sarita. You have finished this case very fast. Thanks for it. So we have more time. But I want to add one more point. I don't know whether I have told this to Dr. Sarogi. I want to just share my experience in 1 minute. In 1982, when my hospital started, after 6 months, I got a case, totally collapsed. She gave a history of 2 months amenorrhea, 2 months and few days. Pregnancy test was positive. Abdomen distended, very pale. That time, the sonography was not available in Bombay that easily. Only Dr. Hemant Shah used to do it. We did abdominal tap, frank blood. So pregnancy test positive, patient pregnant with bleeding inside. The diagnosis was very clear. I opened the abdomen. That time laparoscopy was also not that thing. The uterus was pregnant. The tubes were normal. And patient had a splenic rupture.
Splenic pregnancy, heterotrophic pregnancy.
I had told this story too. The husband had hit her. It's a lower middle class family. And she died on the table in 10-15 minutes. I couldn't save her. 200 crowd was outside my hospital. That time the time was different, so they did not did any violence. I could manage that. Then I confronted the husband, made a PM, coroner's case. That time coroner was there. The husband agreed that he had hit her. Now, this is just from other people's problem we can learn. Never rule out totally trauma in abdominal bleeding. Am I right, Dr. Sarogi, sir?
Yes, yes. Particularly if
Yes.
patient gives history of malaria and Kala Azar, you have to be very, very careful because splenic rupture is very common. Spontaneous splenic rupture.
Yeah.
And probably
After
that
2
is the
years,
role of sonography, where we can get a sonography if it is possible, where we can diagnose the adnexal mass and then diagnose ectopic pregnancy.
True. After 2 years, the same husband came and asked me, Doctor Saab, pehchana, ye meri dusri BB hai, she's pregnant. So the next case is a very, very dreaded thing. It's a 25 years old multigravida patient, came for delivery. Her baby was delivered very fast. She was multi, and she just came and delivered. And the placenta was retained, and she began to bleed profusely. PPH. When will you call this is PPH, Dr. Abhijit Kher? When will you say that this is a more bleeding than what it should be?
Okay. Clinically, any blood loss which makes the patient hemodynamically unstable, we will call a PPH. Though conventionally, we have been taught that in a vaginal delivery, more than 500 cc blood loss and more in a Caesar, more than a liter of blood loss should be considered as PPH. But any blood bleeding which we find more than the normal blood loss in a delivery and which especially causes hypotension or tachycardia should be considered as PPH.
Dr. Komal, how will you assess the blood loss? Dr. Komal is there?
Yes, sir.
How will you
First
assess
would
it?
be the visual assessment. Hello, yeah. First would be the visual assessment. We'll know how much she has bled, what is the amount of the blood present, how she's bleeding profusely. Then the changes in a hemodynamic pattern. If the blood pressure is falling, if she's having a tachycardia, then definitely the bleeding is more. And also the clots. If the blood is coming as a clots, we can visualize the blood clot and can measure the blood clot. And in this case, because the placenta is retained, because in surgery and all, we can even blood about the blood in the suction bottle or even the mops what we have used. So that is a clinical estimation what we do. There are also calibrated drapes also available. Usually they're available at some places wherein a laboring patient, there are drapes, and then they have an calibrated drapes wherein we can actually, the blood falls in those drapes, so we can find out whether it is a 500 or 1 liter or 1.5 liter. So if those such drapes are available, then actually we should make the patients with high risk factors or the suspected PPH to deliver on those drapes, so we can actually clinically estimate the amount of blood loss, because the parameters are falling are in the cases which have become from a severe PPH. They go from the mild to almost moderate to severe. So we should not wait for the parameters to fall, because when we are knowing the parameters are falling means the patient is going into a moderate to severe PPH. So we should try to detect every patient at a mild PPH, because we get that golden opportunity of window to treat and revive that patient or resuscitate and make her normal.
Good. We all know that all these things are okay, but most important is clinical examination. That is the best parameter by which we can detect. Dr. Vijaya Lakshmi, what risk factors where you can prevent PPH? What are the risk factors?
Yes, sir. Risk factors for all PPH, or this particular patient, of course, has a retained placenta.
Any PPH,
So,
any
but
PPH.
any PPH, of course, we know either there has been a history of APH likely to become a PPH as well, or there could be a grand multi or over-distension uterus, multifetal pregnancies, or a low-lying placenta, or the most important is mismanagement of the stages of labor. I think that we should take on ourselves. We have hurried through or precipitate labor or misuse of prostaglandins, inductions, or even in the third stage. Most important is to prevent PPH third stage, we should, I think, active management of third stage of labor is very important. And of course, the way we do a contraction or allow the spontaneous delivery of the placenta. That is very important. And then
Yes,
now, of course, we know we give oxytocins regularly, and at the some give at the delivery of the shoulders, but we give just after delivery of the baby, and then intravenous in the drip already, and also in the 10 units intramuscular, and that definitely takes this thing, and that gives us, and then complete examination. See, we should never lose sight of the clinical thing which we have been doing for years together. The moment we deliver the placenta, you look at all the cotyledons and there is no retained placenta, because nowadays it is definitely not indicated that we put our hand in or try to visualize. So definitely complete delivery of the placenta is important, because these retained pieces are also going to give it to a lot of postpartum hemorrhage. And of course the uterine contractions, whether they are settled or not. All the basics of labor we have to follow.
Yeah, Dr. Sarogi, we all know the causes: atonic PPH, trauma, retained placenta, and of course coagulopathies. The commonest and the most dreaded is atonic PPH. So what is to be done? You know, the uterus is totally relaxed, not contracting. समझ में नहीं आ रहा है किधर से blood आता है. We have examined everything, no trauma.
हाँ, समझ में तो आ गया कि it is atonic. Otherwise, you'll be worried about traumatic PPH. The very fact it's an
See, there's always a dictum whenever there's a PPH like this, call for a help, right?
Okay.
Because all these things happen at the middle of the night, 2 o'clock in the night only, not during daytime. So at what point you will call the help?
Immediately.
Yeah.
Immediately, because by the time you call for the help, the person comes also, it will take some time for the person to come.
So let it be a false alarm, but call immediately. Yes.
Call for help immediately. Maintain ABC.
Yes.
And what is more important, which I want to bring to the notice of August audience, is when we start IV, we have different sets of cannulas starting from G14 to G24. I just want you to know certain things. G14 is orange in color, and it can deliver fluid to the rate of 300 ml per minute. If it is G16, it is gray in color, and it can deliver fluid at the rate of 172 ml per minute. If it is green, it is G18. It can deliver fluid at the rate of 76 ml per minute. If it is pink, it is G20. It can deliver at the rate of 54 ml per minute. If it is blue, it is G22. It can deliver at the rate of 31 ml per minute. And if it is lime, it is G24. It can deliver at the rate of 14 ml per minute. So what is more important is when you put in an IV cannula, particularly in a case of PPH, think of using either gray or green, or if possible, orange in color, because you can infuse a good amount of fluid at one go. Now, as far as WHO is concerned, what their guidelines are, first and foremost, I believe in putting my hand inside to find out if there are retained products of conception, like part of cotyledons or placenta is there, or maybe blood clots. They are also known to cause uterine inertia. If none of them is there, I empty the bladder, because full bladder is also known to cause uterine inertia. Drip has been started. You can add 40 units of oxytocin, which is the first line of treatment. First drug of choice is oxytocin. But see to it that oxytocin was preserved in your refrigerator and not kept outside. Otherwise, the potency is lost. You can start with 40 units, let it run fast over a period of 2 to 3 hours, and see if uterus is contracting. And along with that, you can give 0.5 milligram of ergometrin maleate intramuscular. If you find that this is not effective, we have tried at Cooper. I don't know, Bipin, you were there or not.
Of course, I was there.
You were there. Yeah. We have tried the treatment starting with 300 units. Started with 100 units of pitocin in 500 ml of normal saline, given over at a rate of 90 cc per minute. We try it out for 3 minutes. If uterus doesn't contract, the bleeding doesn't stop, we can add 300 units in 500 ml. And let me tell you, we tried on 14 patients and all of them survived and the bleeding stopped. In fact, we presented this paper. This is by one of our FIGO president only, who has come out with this, by Arun Kumaran. He published it in Recent Advances in Obstetrics and Gynecology 4. And he specifically mentioned that you can try this and it does help in saving a uterus in a case of uterine inertia. So we have tried this with no complications occurring. We were worried about so much of Pitocin going on, but let me tell you, no complications occurred and the uterus contracted very well. So
would you like to tell the audience whether you will start this right in the beginning without wasting time, or at certain stage when prostaglandin, vasoprost and everything doesn't work?
Let me tell you one thing very clearly. As far as prostaglandin and other things are concerned, there are clear-cut guidelines by WHO. First line of treatment is oxytocin. Second line of treatment is ergometrin or ergometrin. Third line of treatment is misoprostol. And fourth line of treatment is alpha methyl progesterone, that intramuscular progesterone, prostrodine. So if PPH is severe type, I don't mind going ahead with this protocol immediately, because the amount of blood loss will be so much. Imagine the pregnant patient's uterus is having 500 to 800 ml of blood circulating per minute. And it's like a tap water which is flowing like tap water. How much of blood loss will occur? You can go ahead with bimanual compression of the uterus. Aortic compression I have tried, but let me tell you, it's useless procedure. I don't think I'll recommend anyone unless until patient is very thin and lean. You can go ahead with bimanual compression. That will help definitely. And in the meantime, if it doesn't work, you can think of doing some surgical procedures. And definitely you have to stimulate the massive transfusion protocol so that you get blood and blood products simultaneously.
Now my question
Vipin, can I add at this point?
Yes.
Dr. Sarogi mentioned different colors and then different types of the ventos, what rate the IV fluid or blood can flow. What is most important is there are high risk factors for PPH, but remember that PPH can occur when there is no high risk factor at all. Patient can develop PPH when patient is absolutely normal woman, and then she can develop PPH. And there will be no time for passing all these 18 number or 14 number or 16 number vein flow, because once she goes in massive PPH, the veins will collapse and we won't be in a position to take these 14 or 16 number vein flows. So what is most important is as soon as patient comes in labor, even if she is in early labor, it's always good to put either 20 number or whatever, put some IV catheter so that we have access to the IV. We can push IV fluids rapidly so that at least vein become prominent, and then later on if she goes in PPH, we can put a bigger number catheter like 14 or 16 number can be put later on when patient goes in PPH.
What about central line?
Central line, I don't think we can put. We'll have to call anesthetist and then anesthetist can. But till then, if we have access to the IV line, we can at least push some fluid. We can push ringer. We can give hemaxil, and at least we can try to maintain her blood pressure. And then once anesthetist comes, maybe we can put 14 number or 16 number or even the central line.
Yeah, Rajeshri, your conservative treatment is not working. When will you start your surgical approach?
So before that, what about the balloon tamponade?
Balloon tamponade.
Yes.
Yes, I think balloon is also a very important thing, because many patients with we have seen the results with the Bakri balloon and all. But how the uterus behaves, that is the most important problem. True. How much she has lost the blood. The clinical estimation is very important in that. We are not going to go and do the hemoglobin and all. As Dr. Sarogi said, sir said, it is within a minute, fraction of, seconds, patients bleeds like a tap water, and there is no there is no time for thinking also. So first is a resuscitation, help, and if she doesn't respond to the medical line or conservative line of treatment, please open. There is no harm in opening and saving the patient's life. We can try for the compression sutures. We are doing most of the patients we have saved with the billing suture also. and that is also working very well. You can take a bilateral uterines also, and you can go for the B-Lynch. We had just finished one case where we took the B-Lynch, took the uterine, the bleeding has control with the 40-50%, we move to the internal iliac. So it has to be done with the expertise and fast till it gets control, and there should not be any gush of the bleeding from the down. But suppose in spite of all these things, we are not able to control it, then we should take somewhere the decision of sacrificing the uterus for saving the patient's life. That is how one should go ahead of that. But what we have found is that in a atonic uterus, always diagnose whether it is a atonic uterus, because most of the times we run with the atonic and there is a mixed picture of traumatic also. So good PV examination is very, very important. And I think Dr. Palip was a unit head. His own case, one time they treated like a atonic in the private. When she came, I did a PV and there was a broad ligament hematoma. Patient was cadaverically pale. And I immediately explored when I was a lecturer. I mean, so these are the things which is very important. So firstly, diagnose whether it is atonic only. There should not be a coagulopathy, no trauma for that. Go for a conservative. If it doesn't help, don't think of, but don't make very late appearance of opening the abdomen. Because many of the times we see the people, they do the atonic, hysterectomy in as good as a patient with a less hope. And patient dies even after the obstetric hysterectomy.
Just one comment here. I want to make. Before going for the surgical management, before opening the patient and doing the conservative management, I don't have any personal experience, but I have heard from a lot of people, and I think Arul Kumaran also has come with a paper. There is something called intrauterine suction. There is something called negative suction. Yes. And a lot of people from South, there is a Dr. Panikar who has used this cannula. And a lot of people from South as well as from other areas, they have said something like a use of this negative suction has really benefited. I don't have personal experience, so I cannot make any comment about this method of. But lately, there is a paper from Dr. Arul Kumaran, which is published, which is also talking about the role of suction cannula for management of atonic PPH. So anybody has used this?
Abhijit, you want to say something?
No, I wanted to ask about the same, whether any of the panelists has experience about the...
Yeah, this Panikar's cannula. Yeah.
I have not experienced, but I have seen his presentation where he has put with...
I've heard him in Foxy. He's about his cannula.
We have heard presentation by the doctor also.
I have used it in one case and it really works.
Worked? Okay.
It worked.
Okay.
I have his cannula. And it has
So, how did you use this method?
See, what you do is, it's a special cannula, something like your regular suction cannula, but with multiple holes.
And bigger one.
Bigger in length and multiple holes. You put it inside and open the suction machine and maintain the suction for about half an hour. You will realize that the basic concept is all the decidua gets sucked inside it. And the blood vessels contract, they constrict, the blood vessels constrict, and there is thrombus formation at those blood vessels. And then you gradually release the pressure after half an hour and remove the cannula, bleeding stops. It has worked.
Is it possible to treat with this method in a milder case or with a severe case?
No, but in his presentation, he has mentioned also...
Dr. Sarogi, one question I want to ask here is, the cervix is open, it is almost 5-6 centimeters. The cannula is a narrow cannula. So how the suction will get generated in the uterine cavity when cervix is so much open? So that was my question.
It's a thick cannula.
What you can do is you put
very big cannula.
It's a big cannula.
Big cannula.
And on top of it, you pack the vagina, no?
Okay, you pack the vagina also.
Okay.
I think...
Doctor, sir, we are finished with this case. Just one or two lines, Dr. Vijayalakshmi, about secondary PPH.
Yeah.
What is the cause and how will you treat it? Just to complete the discussion.
Yeah, we
Patient goes home and comes after few days with the bleeding.
Yeah. Anything after 24 hours, of course, it can go even up to 6 weeks. The most common cause is infection and retention of the products. So if we have missed out on the emptiness of the uterine cavity or some infection flares up, this is the most common cause, and it is definitely all else will be presenting as primary PPH as well. And the best is to admit her and then take care of her. Of course, start with the infection profile, start with her bleeding profile. Everything is important. We do have time maybe at the secondary PPH level because patient has taken her own time to come and report to us. But otherwise, depending on the these things, we will give her antibiotics, cover her up for that, and under cover of antibiotics only we should explore.
Thank you very much. Over to you, Sarita.
Yes. Sir, all through consent and information and counseling in all the PPH cases, however hurried we are, is very important nowadays.
Sure. So one question can I ask Dr. Bipin sir?
Yes, yes.
Regarding that cannula which we were just discussing, I mean, even I have tried it, but sometimes I've got scared because it sort of gives us such a big suction grip.
Yeah, it's scary.
Try to remove it. It is important to release that suction because otherwise you feel you might invert the
Inversion.
Inversion of the uterus.
But the uterus might disappear.
But when you release the suction, and if you release the suction, does the bleeding restart again? So, but all then how long will you keep the suction on?
I have no experience. But
What I have seen in his presentation, he said for a 10-15 minutes you do it. But the thing is, you should not touch to the wall, otherwise it will get perforated. Postpartum uterus is very soft. And
Very
you can
soft.
put the wall inside also, and that will be a very dangerous thing.
Absolutely dangerous, yes.
Dr. Sarogi, what happens after you remove the suction? Does the bleeding start or it stops?
No.
The sir has only one case. He showed that there was one. He showed that there are cases where again it has been
possible. I don't know. I had only experience with one case.
Okay.
I think we'll move to the we'll move to the last case, and the last case.
Bipin, before we move to the last case, can I just make one sentence? I can.
Yeah.
I had a word with Dr. Panikar. In fact, when he presented his talk, I had a lot of questions. How does that cervix close, and then how does the bleeding stop? In fact, we used to advocate packing the uterine cavity so that the blood vessels gets compressed. So when he said that with the negative suction, like Dr. Sarogi mentioned, the uterus starts collapsing, the uterine cavity starts collapsing, and the wall of the uterus gets contracted so much so that the blood vessels stop bleeding, and that is how the negative suction works. So this was his answer.
Yes. I agree. He said the same thing.
Okay, I think we'll move ahead now, and that a lot of food for thought to think. So we have a 30-year-old patient, Gravida 1, 33 plus weeks. She's following up with you regularly, and she has hypertension, she has proteinuria, but she's only 33 weeks. And suddenly the relative phones you and says that she's had a convulsion at home. So my first question is to Dr. Vijay Lakshmi Seshadri. What is your reaction?
My reaction is we need to see her. The patient has to be brought. If we are good at, the hospital facility, she has to be brought here. But of course, convulsion at home, if we can manage getting her. But more importantly, we have to educate a little bit to the patient's attender, if they can manage that if recurrent convulsions are not happening, then she has to be put on the one side and all those things. But
let's go to that later. My question here is Dr. Rajlakshmi. In Mumbai city, he'll say, but how do I transfer her and where do I transfer her?
Nearest hospital.
Nearest hospital in ambulance.
Institute, and it should be now she can call for 108 ambulance if she doesn't have facility. And she has to go to the nearest institute or any hospital where they have the facility of treating high-risk pregnancies.
Yeah, so I think that the important thing is here that we should also anticipate that suddenly somebody calls you at 2 a.m. and says, what do I do? We should know how to have a quick referral and where to transfer and how to transfer her. So now the patient is brought to the emergency room, and I'm going to ask Dr. Komal Chavan, what will you do in the first 30 minutes of seeing her?
If the patient is now come, the first thing is call for help. The whole team should be ready because the patient has come in emergency. She is having a history of convulsion, and the first priority would be her airway, breathing. We need to see because she might convulse again in front of you. So you have to prevent that convulsion That is the main priority. So you will secure an airway, then you will have put a catheter, then you will take a large bore IV line, everything, and the anticonvulsant therapy is the first thing what you will think of, and magnesium sulfate is the treatment of choice, and we would give her the start the magnesium sulfate therapy as per the Pritchard's regime. Give her
So
the
can you
IV
tell us what is the regime? Yes, what is the Pritchard regime?
Pritchard's regime is the standard at 4 grams at IV, which is we give followed by an intramuscular, both is given. So first
we take 4 grams of a 50% solution.
Yes, 4 grams of 50% solution.
4 grams of a 50% solution, is that right?
We'll give 4 grams of 50% solution IV diluted for 3 to 5 minutes, followed by a maintenance of 5 gram IV in both the buttocks. We can give it, and we can continue. IM. And we will continue this every 4 hours. We will be continuing.
Okay. So I'm going to move from you, and I'm going to ask Dr. Abhijit Kher what her BP is 160, 100. What antihypertensive would you prefer? Dr. Abhijit, are you there?
You can ask Reena Mani.
Yeah, Dr. Reena. Of course.
Yeah, so the antihypertensive of choice is labetalol right now. But if you don't have IV labetalol available, you can give oral, not sublingual nifedipine as in an emergency. You can give up to 20 milligrams orally, and it will work pretty fast. If you have IV labetalol, you can give 15 to 20 milligram, not as a very fast bolus, but it can be given IV, and you can repeat it as required. Up to 80 to 100 milligram usually controls the blood pressure in most situations. Ideally, they say you should have ECG facility when you're giving IV labetalol, or it should be done in an ICU setting. Having said that, we have now kept an ECG machine in our own labor ward. So if required, it can be done for the pregnant patient. And one word about the transfer, which you spoke about.
Yeah, and what is the target BP?
The target BP should be around between 140, 150 is also acceptable, but the diastolic should be below 90. So you're aiming at around 140, 90 is also acceptable. You don't want it to crash very low. And also when transferring patients, I feel you should have certain protocols in place because you don't want to lose the patient in transfer. So during transferring, certain things like giving something to control the high blood pressure, maybe giving the loading dose of magnesium sulfate before you transfer the patient, putting in a Foley's catheter, and in fact, if you have the facility, steroids for lung maturity of the baby, by the time you're arranging the ambulance and other things, it takes at least half an hour. So all these things should be done, and a summary of what has already been given should be in place when you're sending the patient somewhere, because we receive so many transfers. I feel I wanted to share these important points.
Yeah. So I think that ideally, if the hospital is nearby and the hospital itself can send the personnel with the ambulance, that would be the best. Do you think that's a good idea?
Yes. Sarita, it is easier said than done. When you are looking at a place which is a referral center, you are not going to get people coming from the referral center to pick up your patient. So you should have some system in place where it's going to happen.
No.
If it's possible, of course, that would be ideal. But let's be practical. It's not doable in this city.
Sarita, I will differ here with Reena. She said that bring the diastolic pressure below 90 degrees. I don't think it is a good idea to bring it very low, because bringing it below 90 is going to compromise the fetal circulation.
Arun, I said up to 90. I did not say below 90.
So between 90 to 1, 90 to 110.
More than 90 is fair enough.
Yeah. So let's have a target of 140 by 90, but not lower than that.
Sarita, in Tamil Nadu, they have given an order, even in the district centers and all those peripheries, that Maxelf should be ready. If somebody throws a fit, they should give it and then transfer towards this. I mean, it's an open order.
But here that's absolutely correct. Absolutely correct. So now we have stabilized the patient.
That is another important point. As soon as patient comes with a history of convulsion at home or at some other place, immediately don't rush and then give magnesium sulfate to the patient, because now awareness of magnesium sulfate is so much that even a general practitioner or
might have given.
Yes, might have given. So don't load, give the loading dose immediately. Inquire and then give.
Yeah, we face the opposite problem in our hospitals where the patient is brought and the casualty gives diazepam before asking. That is the problem that, we are facing in our hospitals. So now...
Suchitra, one more important point. People sometimes give Maxalf assuming if the blood pressure is just borderline. This case, of course, there's a classical high blood pressure, but hypoglycemia can also give, or metabolic cause of convulsion can be there. And once we had a patient who went into arrest, a respiratory arrest, because Maxalf was given in a hurry, but it was actually probably a hypoglycemic convulsion. So hence we have to keep the other causes in mind before rushing and giving medication.
That's true. So let's move ahead now, and we have stabilized the patient. We have done the fluid monitoring, given antihypertensives. I'm coming to, I'm going to ask, I think we will ask Dr. Sarogi sir now. What is your preference for delivery? What investigations and what delivery?
The very convulsion, that means she is a clear-cut case of eclampsia. There is no role of intercurrent eclampsia or conserving such patients and allowing them to proceed further for another 2 weeks or 3 weeks. Go ahead straight away with, if she's a multipara, you feel she can deliver vaginally, try to deliver vaginally by induction of labor. If you feel that she is not likely to deliver vaginally, go ahead with cesarean section and take out the baby immediately.
Yeah. And what investigations are the minimal investigations that we should be sending?
See, ideally, you should find out whether she is heading in for HELP syndrome or not. So the best thing will be doing complete blood count, platelet counts, liver function test, renal function test, and coagulation profile.
Okay. What about the role of steroids in this situation?
Of course, steroids can be given. There's no harm in giving steroids. You should give steroids because it's a 33 weeks pregnancy. So give steroid. Even if you don't have enough time waiting for 24 hours, it doesn't matter. It doesn't matter.
Okay. Dr. Abhijit Kher, coming to you now. What anesthesia for cesarean section is preferable?
In our private setups, as well as BMC hospitals, peripheral hospitals also, we always prefer regional anesthesia, spinal or epidural. Because that keeps the anesthetist hands-free to help us.
In which situation would you feel would this be contraindicated?
If the patient is having continuous convulsions in spite of giving Maxalf, then general anesthesia would be helpful in preventing further convulsions.
Yeah. Any other situation?
If she is hemodynamically unstable, or if there is a fetal emergency, very severe bradycardia, and we have to take out the baby very fast.
Yeah. Arun, anything you'd like to say?
I think general anesthesia will be preferred.
Yes, coagulation.
General anesthesia will be preferred in most of the institutes. But like Abhijit said, the anesthetist may not be comfortable in peripheral hospitals or small nursing homes where patient has thrown a convulsion, and they will prefer a regional anesthesia. Now, again, in institutes, the general anesthesia will be preferred when blood pressure is very high, because it may happen that after regional anesthesia, the blood pressure may suddenly crash, and it may be difficult to control this very low blood pressure. So general anesthesia is better for monitoring as well as for maintaining the blood pressure. And many times, because we have used magnesium sulfate in very high doses, the uterus sometimes may not be contracting, and the surgery also may last for longer time when the regional anesthesia effect may wane off. So general anesthesia may be preferred in such situations.
Okay. Reena, what is the concept of low-dose magnesium sulfate?
So low-dose magnesium sulfate was described from Sholapur. But just to complete the discussion about anesthesia, one important thing is that there are hypertensive responses to intubation also. So general anesthesia is not a first choice unless your platelet count is below 75,000. So if you have a CBC or a peripheral smear, that in most of the cases you can get away with combined spinal epidural is usually good enough unless there's a coagulopathy. And about low-dose magnesium sulfate, it was Professor Sardesai from Sholapur who had presented a lot of data that Indian women are small built and this, but there are not, it is not come into clinical practice, and I would say we cannot recommend it. We have to stick to the Pritchard regime only, and that is what will work for us. The only thing is if a patient has not come with a convulsion and you feel she is imminent eclampsia, there is a place of not giving the IV dose and giving the intramuscular dose as what we would say as a prophylactic measure for convulsions. But we don't follow low dose regimes.
So I think in our hospitals now we are using the IV Maxalf regime, the Zuspan regime, 1 gram per hour. What about the panelists? Are you all also using that?
No, we are using Pritchard only. We are giving the maintenance dose, and for the anesthesia, we are preferring most of the times is a general anesthesia. And what they say is if you give the magnesium sulfate, then the dose of the fentanyl or the propofol, it will be less because causes the less of the blood pressure, and even the tone of the muscle is less in that. So if you give more of the, in a irritating phase, if you give more of the spinal and the epidural, more the chances of having the cerebral irritations are more. So they are comfortable with the GA, and they will adjust the dose according to the what doses of magnesium sulfate has given to them.
Sarita, Zuspan regime is okay when you have one healthcare worker totally monitoring that eclamptic patient. One person has to be sitting with the patient, because it may happen that if person is not continuously sitting with the patient, it may happen that the IV is going slowly and then somebody comes and suddenly increases the drip rate and suddenly...
No, we are giving it through an infusion pump. So I personally feel that avoids the pain of the intramuscular injection. The second thing is it's through an infusion pump, so it can't be tampered with, and you can put it off in case of toxicity very easily, whereas an intramuscular, you cannot do anything.
Okay, monitor it well.
Yes.
I have a question.
In private practice, we also prefer the Pritchard regime.
Okay.
Dr. Rajeshri,
yes,
how long will you continue Maxalf post-delivery?
Post-delivery, depending on the condition of the patient generally, but we practice only for 1 or 2 doses if she doesn't give any, doesn't throw any convulsions in that. The cause of the eclampsia is there are 2 important things. One is remove the cause. So we should deliver the patient as fast as possible. And second is a control of the blood pressure. That is the second mantra. So with that, many of the patients, they require hardly 1 or 2 doses for the maintenance.
But I would like to recall, we need to continue it for 24 hours. Or 24 hours after the last convulsion.
24 hours after last convulsion or 24 hours after the delivery.
Absolutely.
Whichever is later.
May I ask one question?
Yes. Eclampsia, the condition where fetus is not required because it can occur in vesicular mole. Uterus is not required because it can occur in abdominal pregnancy also. What is required is the placenta. So when the placenta is out, your problem gets solved.
Well, that's why I was telling. And with that also...
Sab problem ka jad placenta hi hai.
I'll tell you, if you give more Maxalf, again she will end up in a magnesium toxicity also. So you have to...
Calcium nature.
There is you should go for a 24 hours only. Suppose in a first dose, if she gets a depressed reflexes, you have to hold with the Maxalf.
Rajeshri, of course, you have to monitor the 3 parameters, the urine output, respiratory rate, and based on that, you have to take a call. But if those are within normal limits, it is advisable to continue.
Advisable is okay. But individualization of cases are very important, as rightly said Dr. Sarogi sir, and I also of that opinion only. Once the cause, that is the placenta and the hormones, it has been out, and you have control with the blood pressure and patient is responding, then you titrate the dose of the Maxalf.
Do the tissue changes go away after delivery of placenta? Does the cerebral changes and cerebral irritability go away immediately after delivery of placenta?
See, how then we are getting even postpartum eclampsia suddenly.
Yes. Why do
patient comes even on the 1 week or 10 days after delivery also patient may...
In fact, Dr. Rajeshri, in the maternal death reviews, it has been found that the postpartum eclampsia is the one which is most dangerous and with highest death rate. So I am absolutely not of the opinion to give a message to people that you should stop it individualized. We have to follow guidelines, and in case your patient convulses post-delivery because you have stopped the Maxalf early, you will be held liable. So I think we need to be very particular about it.
For toxicity anyway, you can measure the serum magnesium levels and 2 to 4 nanomoles per liter if they are kept.
Okay.
Of 24 hours also according to the guidelines.
There are so many studies all over.
withhold that dose. That is
One at a time, please.
Let me clarify one thing. If it is an eclampsia occurring antepartum, then the ideal dose of max self will be last convulsion whenever it has occurred for 24 hours after that.
Okay.
But postpartum eclampsia, when it will occur and how it will occur, nobody can predict.
Nobody can predict. Even after 7 days
also it can occur. So nobody is going to start max self after that because nobody predicted it.
I think while on this antepartum, sir, just wanted to ask, Dr. Krishnendu raised this point that in our younger, the residency days, once you give Maxel, it was that you had to deliver. But he said now this has changed. So in eclampsia also, if she's had a convulsion at say 29 weeks, and you have given Maxelf and things have settled down, would you continue with the pregnancy or would you terminate the
No, I think, Dr. Nagarkati, that's a very controversial area because eclampsia and PIH is a multi-organ disease. And even if the convulsion has stopped, the damage to the organs will still remaining. So I think to continue another 2 weeks or another 3 weeks would mean end organ damage to other organs.
Raju, can I say something here?
Yes.
Raju. Yeah. Now,
yes,
if this patient has come at 29 weeks, 30 weeks, and then she is showing signs of imminent eclampsia, maybe you can use prophylactic magnesium sulfate and then continue the pregnancy. But if she has shown a convulsion, if she has become a case of eclampsia, I think we are living in an era where we should induce or terminate the pregnancy. Because we don't know when will be the next convulsion. Maybe there is no healthcare available when she through the next convulsion. So if she has thrown a convulsion, terminate the pregnancy. But if she is imminent eclampsia, maybe role of prophylactic magnesium sulfate and allow pregnancy to continue.
From 83 to 87, we used to have intercurrent eclampsia patients conservatively.
Yes.
And we found very poor results as far as neonatal outcome was concerned, as far as maternal morbidities were concerned. And after that, we gave up the idea of conserving such pregnancies and we started delivering them. This is
yes, I fully agree with that.
Hospital.
Yes, I fully agree with that. Once the eclampsia is set in it, then you should go because there is no point of keeping the patient for an intercurrent eclampsia and guarding the mother and baby's prognosis in that.
Dr. Sarogi, what is the role of CT scan? What point you will ask for CT scan?
See, ideally, CT scan will be required when first and foremost you are not 100% sure about your diagnosis of eclampsia. Convulsion can occur due to many other reasons also. One of them is posterior cerebellar
syndrome.
The Press syndrome.
Press syndrome, which practically mimics eclampsia. So in that case, yes, it will be useful. Or if patients continues to keep getting convulsion post-delivery, you will think of getting a CT scan done.
Status eclampticus.
Sir, one important area is when you suspect cortical venous thrombosis is also an important cause, and that can only be diagnosed by the CT scan. And this is usually presents with postpartum convulsions, or in a patient who you thought was eclamptic. You finished your 24 hours of Maxel, but she's still not stable. So these are the patients where we would like to do a CT scan.
Between the patients who are having recurrent convulsions even after giving magnesium sulfate. Second thing is patient is drowsy, patient is semi-conscious or unconscious. She is not coming out of that drowsiness. In spite of patient delivering, if she remains in a state of semi-consciousness or a drowsiness, which is disproportional to the sedatives which anesthetists have used, these are the cases. Or third is when patient's blood pressure is not responding, patient is remaining persistently high blood pressure in spite of using antihypertensive, then maybe, or she is showing some neurological signs. Then these are the cases where we can get a CT scan done because there may be some other factor like intracranial bleed. Now this intracranial bleed might have occurred because of the convulsions due to eclampsia, and that may be the reason why patient is not coming out of the semi-consciousness. So these are the cases where one can go ahead with CT scan.
I want to make one point, Dr. Sarogi, all these seniors are there. We used to keep these patients in eclampsia room. Remember, there was a separate dark room. And most of these cases, what we have discussed today, obstetric emergencies, are managed in labor room, with everybody coming and going in. Like there is ICU, ICCU, surgical ICU. Why don't we have dedicated obstetric gynec intensive care unit in every hospital.
We must. We should.
We must. In fact,
We have suggested it many times.
Only managing this type of cases.
Yeah.
Because these gynecologists have to insist.
Bipin, I go for the initial
Reena,
inspection.
are you listening?
For medical college.
Yes. There is a dependency.
High dependency.
ICUs, and the grant is there from the Delhi government of India also, and now it is mandatory for the MCI. Now you should have minimum 2 beds with the ICU ventilator facilities available in that actually. So this is happening in many cases.
Minimum 2
Bipin, when I go to the MCI inspection, it is a requirement. Every labor ward, every obstetric hospital should have mandatory HDU facilities. They may not have a full-fledged HDU, but the monitoring facilities and HDU facilities should
it should be full-fledged next to the operation theater and labor room.
Yes.
And with ventilator and everything, all the facilities. Why not?
Government has given for these high dependency units from Delhi. Everywhere the ventilators are available, monitors are available. Even I was in a remote place. There also it is mandatory what Dr. Arun Naik has said. But they are there nowadays for the obstetric and for the gynec, but they go for the sharing with the surgical ICUs. Because sometimes you need multi-speciality, people available, urologists, surgical and all for that purpose.
But Bipin, the problem is not just the providing HDO facilities. It is the manpower which is required.
Yes.
To get
Very true. Very
Multi-speciality,
true.
No. But once the facility is available, the manpower will come. Once the ICU is there.
No, Bipin,
it's very difficult.
It's like train people to monitor.
Now in a district places and all, you can call for an opinion and you can pay for them also from the PLA fund also. And in the institute, definitely you will have the specialists there. And for the nursing homes in the cities, these people they can ask for the specialists also.
No, my point is how the anesthetists are becoming intensivist. Some of our gynecologists can become intensive gynecologists.
Yes.
They can get trained.
Yes, they should get trained. I agree with you.
Yeah. But there should be position. There should be some position like this, that intensivist position for managing obstetric emergency patients. Even today, BMC is not recruiting new people. There are so many vacancies as assistant professors. There are so many vacancies for professors.
No, if we insist, everything can happen.
No,
Nothing
I think
happening. We have been writing letters.
We have been insisting, Bipin sir, but the answer is that we don't have class 3-4 employees also. We don't have enough nurses also.
I think we are running out of time and
I think we'll wind up now.
I think we wind up now.
We'll wind up and we'll, Dr. Bipin Pandit, would you like to have the closing comment?
Yeah, thank you very much. And it was a very interesting discussion. And I'm sure it can become unending. We can just go on and go on, but it's more than 2:15. And the conveners, thank you very much, Dr. Rajendra Nagargatti and Komal Chavan, managing it, and Dr. Reshma Pai, MOGS President, and Suchitra Pandit, our ISOPAR Dynamic President.
On
Thank you
behalf
very
of
much
all
for
my
giving us this opportunity. And we also enjoyed moderating this. I'm sure everybody who has listened, they've enjoyed.
On behalf of my co-panelists, I
would
think
say
I will
both.
also thank Dr. Bipin and Dr. Sarita, as well as Dr. Nagargatti and Dr. Suchitra and everyone for a very interesting.
Thank you everyone for being there.
Over to Rajendra.
Thank you, everybody.
I just said thank you everyone, all big stalwarts in the program. It's such a wonderful program. It was great, and we had more than 400 people still logged in. That was a good thing, great thing. So I think it's. I'll hand it over to Dr. Komal to give the formal vote of thanks. So over to you, Dr. Komal. Thank you once again, everyone. Thank you.
Thank you, Rajendra.
Thank you so much.
MOCs also, Sargam, Soni, and Amita.
Thank you so much. Thank you.
Thank you. Thanks a lot. I thank you all from bottom of my heart on behalf of MOGS and the ISOPAP Mumbai chapter. And I thank Dr. Suchitra Pandit and Dr. Reshma Pai, President Dr. Anaita Chavan for being here and guiding us for this webinar. I thank Dr. Rajendra Nagargatti, the co-convener. He has so nicely planned all the faculties, and it was a real wonderful discussion right from all the talks given by Dr. Shreya Prabhu, Dr. Bhumika, and Dr. Krishnendu sir and Ashok Kumar. They were so practical and a lot of insight and practical points were covered. And a wonderful panel which was moderated by Bipin Pandit and Sarita Bhalerav. It was real revisiting the emergency labor ward and seeing so many high-risk cases at one time. And we had a galaxy of panelists from, I think, representing all the heads of all the medical college from Sai and Dr. Arun Naik, Dr. Rajeshri Katke from JJ, Dr. Reena Mani from Cooper, and the boss of all, Dr. Sarogi. So it was real power-packed panel with Dr. Abhijit Kher and Dr. Vijay Lakshmi Sheshadri, our external guest panelist. So it was a real wonderful discussion. I think we all have enjoyed, and the viewers, all that is amounting to almost 400 plus. That is real great for a MOGS and ISOPAP program. And I thank our sponsors, the Sun Sonora division, for bringing us all on this platform. And thank you all for enjoying this webinar, and do stay tuned for more programs from MOGS and ISOPAP. Thank you so much.
Thank you.
Total attendance was 475.
Wow.
Thank you.
Great.
That's good.
Great.
Thank you.
And thank you, Sargam Soni and Amiti. They have done the fabulous job as our MOC. They are the stars of the day.
Yes.
Thank you. Thank you, Komal. Thank you.
Sargam has done a lot of coordinating work. Thank you, Dr. Sargam.
Yes.
Thank you, Sargam.
Yes.
Thank you.
Now one song from Dr. Bipin and from Dr. Sargam.
Arey nahi. Next time.
I love it.
People are hungry.
Yeah, okay. But when you all are around, always we think of music.
Next time. Thank you.
We will start with music.
Yeah.
Bye.
Bye.
Okay. Thank you once again, everyone. Dr. Romesh, Dr. Somin, and the entire Sun Inca team. Thank you very much.
Thank you.
Thank you.
And sir, thank you, sir. Sarogi sir, for being such a wonderful.
For inviting.
Thank you, sir.
Yes,
Thank
bye, sir. Thank you,
you.
sir.
Abhijit, thank you. Vijay Lakshmi madam, thank you.
Thank you. Thank you all.
Rajeshri madam, thank you. Abhijit, thank you. Everyone, thank you. Wonderful. Thank you.
Thank you.
So I think we log out and have a wonderful Sunday.
Yes, sir. Thanks, sir.
And thank you, sir. Thank you, sir, for taking so much time.
Not at all. Our pleasure, Soman. Thank you.
Yeah, so nice, madam, sir. Well organized programs it is. Thank you for one and all for taking so much time and making a program so grand success. We have almost attendance of 700 approximately. 600 attendance is there. So it was a very good attendance and really appreciable and commendable job, sir.
Thank you, sir.
For great coordination.
Thank you, sir. Thank you.
Thank you, sir.
Thanks, sir. Thanks.
Thank you, Sargam. Thank you. Soman, I'll need the figures also for the so whenever the
right, sir. Right, sir.
The online
Sure,
figures also and the Zoom figures. Okay, I think 475 been said, and they think some must be online.
Right, sir. Right, sir.
Yeah. Okay. Thank you, Soman, once again. Great.
Right, sir.
Thanks.
Thank you, sir.
Thank you.
Kishorji, we can close the meeting.
Yes. Thank you.
Thank you. Thanks a lot.
Yeah. Okay.